All right, it's 9 o'clock. Good morning, good afternoon, good evening, everyone. Welcome. Thank you for joining today's event, CIRA at Yale Symposium, addressing HIV/AIDS, mental health, and substance use in humanitarian settings. My name is Dini Arsono. I work at the Center for Interdisciplinary Research on AIDS at Yale University. It is a AIDS research center funded by the National Institute of Mental Health. So today's symposium is being recorded, and we will go through the agenda very briefly in a moment, and also this link to the symposium program will be posted on the chat. We encourage you to have your video on, but your mics off. But if you want to turn off your video, that will be fine too. And the recording of the session, the PowerPoint slides, and other resources, as well as evaluation survey, will be posted and shared after the event. And if you have any technical difficulties, I would suggest to contact Pete Donahue, listed on as one of the co-hosts of the event. And then this event is interactive, so please use the chat panel and type your question for the speakers and panelists. We will do our best to answer all questions over the course of the symposium and after the event as well. A very quick overview of the symposium program. We will start with welcome and introductory remarks. We will introduce each of our speakers at the beginning of each session. So following the introductory remarks, as you could see on the slides, we will have a presentation on program and funding opportunities information from the National Institute of Health. And the second session will focus on research projects conducted in humanitarian settings. And the third session will include perspectives on healthcare and social support services, a conversation with practitioners, providers, and community members. The fourth session will be a discussion with all speakers, panelists, and as well as audience. And we will wrap up with some information as well as next steps. And with that, I will give the floor to Dr. Kaveh Kusnut, who is one of the co-chairs of the HIV/AIDS Humanitarian Setting Program at CIRA.
Thank you so much, Dini. I'm Kaveh Kusnut at Yale School of Public Health. I'd like to welcome you. I've had a long interest in HIV/AIDS work in the last about 3 decades. And over the last 7, 8 years, I have brought in an interest in humanitarian crises and how that impacts HIV/AIDS. That work primarily started in Lebanon and has now been expanding. We have a terrific organizing team that Dini mentioned. We have 3 of our public health students supporting us. And this project was funded by NIMH, the P30 grant, led by the principal investigator, Trace Kershaw. And we also received some funding from the Yale Macmillan Center to conduct this symposium. In terms of what our focus is, I want to just mention to you that when we talk about humanitarian crisis, we are thinking about both natural disasters, environmental events that can cause considerable morbidity and mortality. These could include droughts, floods, storms, earthquakes, etc. But we're also thinking about complex emergencies associated with fragile states or areas of conflict. And we are interested in understanding how these situations impact people at risk for HIV/AIDS and people living with HIV/AIDS. We recently published a scoping review protocol that you can see factors associated with HIV acquisition in the context of humanitarian crisis. You're welcome to take a look at that one.
So we'd like to start this morning with a quick poll just to get to know you as an audience better. And you'll be able to see on your screen popping up now the opportunity to vote on these 3 questions and just share a little bit about yourselves. The first question is, which of the following best describes your role? And you'll see a number of choices. Please just scroll down in the drop-down menu and select what best captures your role. What best describes your primary institution organizational affiliation is the second question. And then what do you hope to gain from today's symposium? So we'll give you just a few moments to answer those questions on this screen and submit your responses. And then we'll show the results on the screen just to have a sense of what this group is that's gathered here today. Great, and as people are finishing this up, I'll ask Pete Donahue to share the results on the screen.
I think I would have to end it first if you want to let the rest answer.
Great, thanks, Pete. Great, so we have about 80% participation, so I'll go ahead and end the poll so we can see what people think. Great, so you should see on your screen that we have about 25% characterize themselves as healthcare or social service providers. About 25% are researchers, and that's really great to see a balance. We'll be covering both of those topics today in the second and third session. We'll also be talking, of course, about funding, and I know that's something that's of interest to everyone at the beginning. In terms of primary institutional or organizational affiliation, we have 63% who characterize themselves as being associated with academia, either a university or a research institute. About 22% are coming from a healthcare organization, a hospital, or a clinic, and I imagine, of course, there's some overlap in those areas. And then finally, in terms of what do you hope to learn from today's symposium? The majority are looking for a better understanding of HIV/AIDS related and health research conducted in humanitarian settings. Many are interested in understanding the health needs of communities who may be impacted by humanitarian crises, looking for resources and learning opportunities for researchers to develop research around this topic, resources and learning opportunities to build capacity for those that we're working with in communities that are affected by humanitarian crises. And of course, networking is another important reason for participating today. So thanks so much for sharing that. I think it's always nice to know who's in the audience, even though we aren't necessarily sitting next to each other.
To get started, I'd like to invite my colleague, Professor Frederick Altes and Alexei Zelenov to give a brief overview of what's going on in Ukraine and how it's impacting the HIV/AIDS work that they've been conducting for many, many years. Professor Altes is a professor of medicine, epidemiology, and public health, a clinician, a clinical epidemiologist, an intervention and implementation science researcher at Yale School of Medicine and School of Public Health. Dr. Altes's primary research focuses on interventions and implementation science at the interface between infectious disease and addiction, as well as projects working in a criminal justice system, including transitional programs addressing infectious diseases, medications for opioid use disorder, mental health, mental illness, homelessness, and social instability. Dr. Altes has conducted research in several global health settings, including Malaysia, Ukraine, Moldova, Armenia, Kyrgyzstan, Peru, and Indonesia. And in addition to Fogarty, NIH agencies, and CDC, has been collaborating with WHO, UNAIDS, USAID, PEPFAR, and UNODC. Rick, thank you so much for joining us today. I know the situation in Ukraine is very, very dire, and you've been doing everything you could to support your colleagues. We would love to hear from you.
Sure. Thank you, Kaveh, and Luke and Dini for inviting me to participate. I would say that the last 40 days have really brought to the forefront the importance of engagement during humanitarian crises. And, I'm coming at this both from a researcher who spent the last 18 years heavily invested in scaling up HIV prevention and treatment in Ukraine. So not only has this been, the perspective of research, but you can imagine that I have hundreds of colleagues with whom I have worked and continue to work in that area who are all individually impacted by the war that is the unprovoked war that's going on in Ukraine right now, as well as the individuals and organizations across governmental and non-governmental organizations throughout the entire country. Our work is very broad and has included, I would say, what I would call the sort of the appetizer for all that has been going on, because we were working in the country in 2014 when that Crimea was annexed and the Donbas region was in pretty significant conflict. I will say that part of the reason for continuing to do the work literally on phone calls and group meetings on a daily basis now is really predicated on the fact that implementation science really provides an incredible framework to be able to also contribute to helping during a period of crisis. We are really using our collaborative learning process. We call it NIATEX, but our collaborative learning process to bring together multiple stakeholders across many different areas to do this work. And one of the things that we learned in 2014 is that the risk for HIV prevention and treatment is incredibly dire. By taking the example of Crimea, where 800 people on methadone were discontinued summarily within the first 10 days of annexation. And so part of our implementation research then involved really relocating 200 of those individuals into more stable areas within the country. But unfortunately, we continued to study what happened, and the epitaph on that is that of those 600 that remained, 10% of them were they were dead within 6 months, mostly to overdose and to suicide. And then, of course, the HIV outbreak with the discontinuation of effective HIV prevention has been extraordinary. Continuing to work in the Donbas region also provided guidance on how to continue to have supply chains and to get medications to people who needed it, as well as to additional services. But now the magnitude is extraordinary, and I'm sure that many of the other speakers are going to speak to really the issues around supply chains, continuing evidence-based HIV prevention. And we already have stories from the field of our methadone clinics that have been bombed, annihilated. One of my chief addiction treatment doctors that I've been working with for a decade now, his clinic in Mariupol was completely destroyed. He barely got out of the city with his wife and 2 children, only to relocate to another area, not having a dime to his name. And part of our implementation has been to stabilize these individuals. But I also want to point out that there are individual human costs, and I will use this as an example. The stress of moving and the conflict and seeing his city completely razed resulted in him having a heart attack, and his wife having pretty profound trauma and stress around all of this. So I want to say that while we look at the photos, we read the news, we listen to the commentary, there is so much more that's going on. And it is important to go from dialogue to service delivery and making a difference in all of this. And I'm sure that we are going to learn so much from our many colleagues about how we can make a difference and how we can actually impact the lives of those who are in the throes of a humanitarian crisis. Thank you very much.
Thank you so much, Rick. Really appreciate that. We also have Alexei Zelenov, CIRA affiliated scholar and research assistant who's been working with Dr. Altis in Ukraine for a long time. Alexei, if you have anything to add, feel free.
Yes, thank you so much. And thank you for giving me a chance to speak. which I very cherish very much. I grew up in the States, but I was born in Russia and I worked in Ukraine for the past 7 years. And I'm absolutely devastated by the atrocious war that Putin launched on Ukraine. My personal pain runs deep, but that pales in comparison to the strife experienced by my dear friends and colleagues who are suffering immensely, many who experience bombings directly, and many had to evacuate or seek refuge in other countries. The war is a catastrophe that brings death and destruction, and long-term consequences of the war will still need to be understood. Our immediate work in Ukraine has been more challenging, and so some of the projects have been outright disrupted, while other projects face uncertainty. I would say that the overall healthcare system is under disproportionate stress, that the new outbreaks and health emergencies threaten to wipe out the gains that were made over the past decade. So currently there are extreme shortages in medical supplies and drugs. And in the context of HIV prevention, this covers access to ART and well as substance abuse treatment. And the logistical problems derived from the war exacerbate these challenges. There's a cascading effect, and I think the war has turned a very volatile situation into a full-scale emergency. It's also forcing us to not only continue to do our work, but also to rethink the notions of vulnerability and sustainability. And in some ways, the sustainability has to reflect resilience. And in the past, I served as an advisor to World Health Organization in Health Emergencies Program. And it was evident through the work that COVID was already taken a large burden on the healthcare system. And the stress has overstretched the healthcare system, that there were immediate evident capacity constraints, there were inefficiencies in management and shortages of personnel. And the war amplified in many ways these structural weaknesses and exacerbated the existing shortcomings. And in some ways, the toll of this conflict will pose not only short-term, but very much long-term consequences that we will have to understand and deal with. And it's an important time period. So.
Thank you, Rick and Alexei, for sharing your insights and information, what's happening in Ukraine. It's absolutely a dire situation, and we hope we'll be able to support you. Thank you so much. I'll turn it over back to Dini.
Thank you, Kaveh. And with that sobering note, but also highlights the importance of the work of our colleagues who are able to join us today in this event. I would like to introduce the speakers to our first session, which is the information on National Institute of Health programs. And the first speaker is Dr. Holly Campbell Rosen. Holly, you may be able to set up your slides now, and I'm going just to read briefly your bios. And so Dr. Holly Campbell Rosen is a program officer at the National Institute of Mental Health in the Center for Global Mental Health Research and Division of AIDS Research. Holly is advancing research on mental health challenges experienced by mobile populations, including migrants, forcibly displaced people, labor migrants, and other key populations, and the impact of mobility on HIV outcomes. Prior to joining NIMH, Holly managed an extramural research program on psychological trauma at the Department of Defense. As an AAS Science and Technology Policy Fellow at NIH, she supported policy development of federal advisory committees and reported to Congress on stroke and childhood disorders at the National Institute of Neurological Disorders and Stroke. And our second speaker of this session is Blythe B. Croft. Blythe is a global health research and policy analyst at the Fogarty International Center at the National Institute of Health, Within the Center of Global Health Studies, her portfolio includes projects covering health research in humanitarian crisis, equity in health research, emergency care research in low and middle income countries, the integration of HIV and CD platforms and care, and implementation science in global contexts. Blythe received a master's in global health from Georgetown University and a bachelor's in international relations from Brigham Young University. And with that, Holly, if you want to start your presentation.
Can you hear me okay?
Yes, I can hear you fine.
Are my slides okay?
No, it's not shared yet.
It's not? Oh, I apologize.
No, that's okay.
And now, can you see it?
Perfect. Yes, it's on full screen now. Thank you.
Okay, thank you. Well, thank you all for inviting me. I'm pleased to be here. As Deanie said, I'm a program officer at the National Institute of Mental Health. I'm in the Center for Global Mental Health Research and the Division of AIDS Research at the NIMH. And today I'll speak with you about our programs on human mobility and HIV and mental health. I was going to take a moment to reflect on the displacement of people around the world, but I would like to thank Drs. Aptis and Zelenov for their beautiful accounts and reflections. Human mobility is broadly defined as movement of individuals or groups in space and time and includes livelihood mobility, displacement, and migration. Globally, the number of the world's mobile populations who are displaced are at record highs. The number of refugees grows annually, and the pressure to migrate is increasing for many, particularly those in low resource settings. Drivers of mobility include geopolitical, religious, or ethnic conflict, war, natural disasters, climate change-driven events, violence, and infectious diseases, among others. Migration exposes mobile populations to social and structural determinants of health, which may also act as impediments to security, obstacles to accessing basic needs, and barriers to engagement with healthcare services. Although it is not fully understood how drivers of mobility interact with social and structural determinants of health, both are significant factors that may exacerbate mental health inequities and may underlie increased health risks and poor health outcomes. Some factors can serve as both drivers of mobility and social determinants of health. It has been long understood that the human mobility plays a significant role in the acquisition and transmission of HIV and contributes to poor HIV outcomes among mobile persons or populations. In the next few minutes I will briefly introduce you to our Division of AIDS Research, mention some of our priorities, and speak to you or show you some examples of the type of research we have funded. The NIMH Division of AIDS Research has 3 foci: behavioral science, mental health, and clinical neuroscience research. All of these are in support of research to reduce the incidence of HIV worldwide and to decrease the burden of living with HIV/AIDS. The division also has a priority on interdisciplinary research across multiple populations, and this includes mobile populations. Some of you may know that we hosted a workshop last year on human mobility and HIV. One major outcome from the workshop has been to refine the program's priorities, and to advertise to the community that we are interested in research on mobility and HIV. This list of research priorities is not exhaustive, but gives you an idea of what our program is about. For example, on the blue bullet on the upper left, supports research to incorporate mobility data and HIV transmission data to understand the role of mobility and HIV acquisition among mobile populations and the resident communities. And on the upper right, one priority is to optimize effective HIV preventive interventions for high incidence communities and HIV treatment provision for people living with HIV during migration and in humanitarian settings. And I should point out that this link at the bottom of the slide is to a description of the research program. This is a high-level overview of the types of research we have funded to date, showing the research focus, methodologies, and populations. And this slide highlights the current mobility and HIV grants that we fund. If interested, you can learn more about them at the link at the bottom to Reporter, an NIH database, where you can read their abstracts and additional information. And you can see there's a range of types of mobility and focus on different interventions or modeling and so on. Now I'd like to transition to mental health, and I'd like to say something that I didn't explicitly say on the HIV part, which is mental health is clearly linked to the HIV component. So if you're interested in working on HIV and mental health, we are open. We clearly are interested in that type of work. Mental health affects all sorts of behaviors and outcomes in HIV. This part of the talk is more focused on mental health and human mobility specifically. In the Center for Global Mental Health Research, we have priorities that run across the research pipeline, but I would say that we have a heavy emphasis on the services research end and translational end as well, and we're moving more toward the discovery research end. This is a list of some of our priorities. Among most people affected by emergencies will experience psychological distress. Most will experience that psychological distress. Most will improve over time. Yet, a recent study has found high and persistent rates of PTSD and depression among refugees and asylum seekers. And this list of research priorities is not exhaustive, like I said, and I'd like to draw your attention to the blue one. Implementation studies, a lot of our work is in implementation science. And we have a real emphasis on working with humanitarian relief agencies and governments to adopt and scale and sustain evidence-based interventions in humanitarian settings. This is also a high-level overview of the types of research we have funded to date and the methods and populations. And here is a list of grants that are currently open, and you can see that they range from study of refugees to people who have I believe there's some formerly incarcerated people in the list, different populations who have been mobile. Recently in February, I received approval by the NIMH Council for a concept called Improving Mental Health of Mobile Populations through Prevention, Diagnosis, Treatment, and Implementation Approaches. It's a very broad concept under which RFAs can be produced, and you may read the concept at this link, and keep your eyes out for future funding opportunities aligned with this cleared concept. And in the meantime, we invite you to apply for our open funding opportunities listed on the next slide. So the top 3 are actually Fogarty opportunities. They allow investigators to apply and identify institutes that they would like, that they are aligned with, their work is aligned with. So many people apply for mental health research grants through these mechanisms, and they're quite popular for that. We also receive HIV grants through these mechanisms. And then we have 2 more recent specific funding opportunities. And then we have lists of parent funding opportunities at these links here. And I believe that's all I have. Happy to take questions after my colleague Blythe presents.
Thank you very much, Holly. Just a reminder to all the audience that the slides will be made available in the coming week or 2 weeks, including the links that Holly just described, as well as Blythe Beecroft slides from the Fogarty International Center. Thank you. Go ahead.
Thanks, Dina, and thanks, Holly. So as was mentioned before, I'm a global health analyst at the Center for Global Health Studies within Fogarty. Just for those of you who are less familiar with the Fogarty International Center, we are the smallest of the 27 institutes and centers that make up NIH, but we are specifically tasked with looking at and funding global health research worldwide. So we like to say we have the largest reach. Within Fogarty, I personally work at the Center for Global Health Studies, and I wanted to clarify that this is not Fogarty's grants division, although we do work very closely with our colleagues there. The Center for Global Health Studies instead operates more like a think tank, a global health think tank, or a hub for project-based scholarship. So we work to identify important or emerging global health issues, and we'll then organize collaborative and multidisciplinary projects around those issues that result in a variety of different deliverables ranging from workshops, toolkits, publications, case studies, all across the board, depending on the nature of the project. One of these projects is our project on health research in crisis settings, which actually was first developed in 2017. And this project, I will echo, like the Symposium, we're looking at crises with a very broad definition. So this is inclusive of natural disasters, conflict, forced displacement, and epidemics. So the 2 main goals of our project at large are, first, we are working to catalyze timely, high quality, ethical, and actionable research in crisis settings. And then the second is that we're working to strengthen the capacity of scientists, especially from LMICs, to conduct health research in these settings. We have 2 scientific project co-chairs, Iman Wahid from the American University of Beirut, who actually is on sabbatical right now at Yale, and then Brandon Court at the George Washington University. So I wanted to give you kind of an overview of our project to date and what we've learned along the way. So this project was launched with a workshop we held at NIH in 2018. The purpose was to bring together researchers from across the globe, across different types of crises and disease areas, together with international and local NGOs in the humanitarian space to talk about what was the state of the science, what were the main challenges and barriers to conducting health research in crisis settings. So that was very informative and really allowed us to frame our thinking in different work streams. What followed next was a publication in BMJ Global Health, where we really issued the call that conducting health research in these settings is an urgent global imperative. From there, we commissioned and funded a collection of case studies, which has been published across both conflict and health and BMC public health. And these case studies go beyond traditional research papers in that they focused and honed down on how this research was being conducted, what were the specific challenges specific to the settings that the researchers encountered, how did they have to change or pivot, adapt their methodologies, and what were the lessons learned. So that collection was published, and then most recently in November of 2021, we hosted a virtual meeting, which was the first global forum on humanitarian health research. And this was designed as a way to bring together researchers and humanitarian organizations to a meeting that was centered around specific case study presentations, mostly by LMIC scientists who are early and mid-career. And the idea was to, again, foster collaboration, share specific learnings, but then a gap we had heard in our initial workshop was difficulty forming a community of practice in this space that cut across different disease areas and types of crises. This was our pilot meeting, so the theme looked at research in the context of concurrent crises, which was relevant with COVID-19, the COVID-19 pandemic. And this was done in partnership with IDRC in Canada, the Wellcome Trust in UK MRC. Some key learnings as we've developed and worked on this project, our co-chair Brandon Court likes to say you can't build a hospital without an emergency room. And that is to say that health research in crises is integral and essential to global health. You can't have global health without humanitarian health. They're not separate. We also have really felt that although response is obviously the first and most important priority, that there is a clear need for more research in these contexts, and there are evidence gaps that we should not ignore. Community engagement is essential, and also that partnerships with humanitarian organizations are very critical to successful and high quality research for a variety of reasons and do help with research uptake. In terms of future directions, we are going to continue to work on advancing the Global Forum on Humanitarian Health Research and seeing how that can continue to be useful to building community of practice for low and so early and mid-career researchers. We also are in the scoping phase of a work stream looking at community engagement in crisis settings. A couple other areas, additional topics of interest that we could potentially incorporate into this project at large. And then briefly to conclude, I'll give a little bit of a funding overview to build upon what Holly said. There are no dedicated programs at Fogarty or an NIH specific to health research in crisis settings, but the topics are relevant. Actually, from 2009 to 2018, there were 70 individual awards that were relevant to the topic, funded by 12 different ICs. I'd like to highlight that there are a lot of training and research opportunities that are specific to LMICs that could include health research in crisis settings. It's kind of an opportunity to think outside the box. As Holly mentioned, we do have the Fogarty Brain Program, and that is a great opportunity and a way to look at topics like mental health and disasters. So my advice would be don't look only for health research in crisis explicit opportunities. And again, to echo Holly, parent announcements are another great opportunity for looking for funding. Those are for unsolicited or investigator-initiated applications, and those are generally very broad, so there's definitely room for creativity there. In the interest of time, I will just encourage you, again, to look at the Fogarty Programs website, but these are specific programs that we have, training programs, other funding programs that could definitely be relevant in the health research and crisis space. And then finally, another research I would point out is the NIH Disaster Research Response, DR2 program, and the webpage actually provides an incredible resource portal. So there are different tools, and this is housed by the NIEHS, the National Institute on Environmental Health. And I would encourage you to look there, also a great opportunity. And then finally, I think the best advice is if you see a potential funding opportunity of interest, contact the scientific contact listed to just check with them, talk to them. I think that is one of the most important steps that can be taken. And then finally, I would encourage everyone to sign up. Fogarty has what we call our funding newsletter, and I can share the link in the chat shortly, but this is a way to receive updates not just on Fogarty funding, but also opportunities related to global health at large across all institutes and centers. We also have a section that's specific to opportunities for which foreign organizations may apply, and any new funding opportunities related to health research in crises will appear there. So thank you again for your time. I'm happy to be contacted for any other questions. And I'd like to acknowledge my colleagues, Nalini and Amit, who help lead this project at Fogarty. So thank you.
Thank you, Blythe. That was really helpful. And I really like the key points where the resources that people might find interesting to get more information about funding opportunities and also programs at the NIH. So I don't see any questions enter in the chat. Some of our participants have submitted questions ahead of time during the Zoom registration. So one question maybe for Holly, but also Blythe could chime in. A question is how much of the research funded by the NIH is conducted in Global South compared to the Global North? Maybe it's you know, the humanitarian crisis, such as the natural disasters also happen like in the US or in other Global North sites. So could you provide an overview of you know, the list of the projects that Holly presented, how many others are conducted in the South compared to the North? Thank you.
Thank you for the question. So for the Center for Global Mental Health Research projects, the second set of studies I presented, they will all be taking place in low and middle income countries. We do not fund high income countries from the center. Our mission is not aligned with that. The rest of the Institute funds research in high income countries as well as LMICs. But our mission is aligned with funding LMICs. That said, the HIV ones, I would have to go back and look at them. Probably many of them are in LMICs, but there's a potential that some of them could have been in HIC, perhaps the US. And I don't know in terms of percentage or dollar amount off the top of my head. So unfortunately, I can't answer it in those terms.
Thank you. Blythe, do you have any comments on that?
Again, it's a unique, I would echo Holly in that I do not know off the top of my head for NIH at large. It's unique working at Fogarty because again, we are focused entirely on health research in low and middle income countries, which is definitely unique, but yeah, I couldn't speak to with confidence anything across all NIH institutes and centers.
All right, thank you. Thank you so much, Holly and Blythe, for your presentations and comments. And so in the interest of time, we will continue to the next session. So Dr. Luke Davis, who is another co-chair of the HIV/AIDS Humanitarian Crisis Program at CIRA, will moderate the session. Dr. Davis.
Great, thank you, Denny, and thank you so much for the excellent presentations on NIH initiatives. We'll now move to talking a little bit about research perspectives, and we're delighted today that we've been joined by two well-established researchers in this area, Dr. Jeremy Kane and Dr. Kelly O'Loughlin. I'll introduce each of them and then give them a chance to give their presentations. So Dr. Kane is a psychiatric epidemiologist and assistant professor of epidemiology at the Columbia Mailman School of Public Health and a member of the faculty steering committee for the Columbia University Global Mental Health Program. Dr. Kane's research investigates the impact of culture and of migration on substance abuse and alcohol use patterns and how these relationships are experienced with trauma and co-occurring mental health problems. He also does work on valid and reliable methods for measuring substance abuse and mental health across different cultures and uses techniques to adapt, test, and implement intervention strategies to try to address some of these challenges. His work concentrates on these issues both globally among HIV and trauma-affected populations in low and middle income countries, as well as domestically among refugee and immigrant communities who are living here in the United States. And his work has been widely funded by NIH, CDC, WHO, USAID, and the United Nations. So I'll go ahead and turn the forum over to Dr. Kane. He'll give a presentation for about 20 minutes, and then we'll hear from Dr. Kelly O'Loughlin, who I'll introduce just before she speaks. And we will have time at the end for about a 15-minute question and answer session. So as with all of the presentations today, please be thinking of your questions and enter them into the chat. Thanks so much, Jeremy, for joining us today, and I'll turn it over to you.
Thank you so much, Luke. Good morning, everyone. So nice to be with you all. Thank you very much to CIRA and to Yale for hosting, a really fantastic symposium on just an incredibly important yet often understudied and unaddressed topic of HIV, mental health, and substance use in humanitarian settings. Really grateful for the invitation to be with you all and to share a panel with Kelly, whose presentation I'm very much looking forward to as well. And so my talk is going to be focused on alcohol and substance use in humanitarian settings, and specifically talking about an intervention approach known as a screening, brief intervention, and referral to treatment program that we're currently working to adapt and evaluate among a refugee population in Zambia, which is in Southern Africa. And so as a starting point, I'm what, as Luke sort of mentioned, what you would call a global mental health researcher. I work in global mental health. And so a question that some might have is, why within a global mental health field would we want to focus on alcohol and other substance use? Why not just focus on PTSD and depression, which are commonly discussed mental health concerns among humanitarian affected populations? Well, when you read the literature in global mental health, you often see described that we are a field that aims to address mental, neurological, and yes, substance use problems globally. These are the so-called MNS problems or MNS disorders, right? It looks something like this when it's written. But in reality, it's actually more like this, at least from my perspective. You almost have to squint sometimes to see the S in MNS disorders. And what I mean by that is that in reality, research into alcohol and substance use problems within the field of global mental health, and by extension in global mental health research in humanitarian settings, has been relatively neglected compared to depression, to anxiety, to PTSD, and the list goes on. So I think it's important for us to recognize at the outset that substance use has been understudied in the global humanitarian context. That is just a fact. And this lack of attention is problematic, right, for several reasons. Alcohol and substance use disorders are not only highly prevalent globally, they are also highly burdensome, meaning they cause a great deal of morbidity and mortality. They commonly co-occur and are comorbid with many of the mental health problems that many of us associate with global mental health and with humanitarian affected populations, again, such as PTSD, depression, anxiety, and they are largely unaddressed themselves. There is an absolutely enormous treatment gap for substance use disorders in low and middle income countries, and especially in humanitarian settings. So in humanitarian settings, the epidemiological literature on alcohol and substance use is limited, right? There are a number of challenges to doing this type of work, which we'll talk about at the end of the presentation. But suffice it to say that most prevalent studies that have been done have some pretty significant methodological limitations related to things like sampling and measurement. But still, even given those limitations, the literature does suggest that the risk for unhealthy alcohol and other drug use appears to be elevated among populations in humanitarian settings. And this could be the case for several reasons, right? One could be access to illicit substances may increase. And so in camp or other humanitarian settings that are unstable, drug enforcement policies and security may be reduced or non-existent. Second, exposure to conflict, to disaster, to other potentially traumatic events and related stressors to the humanitarian environment can precipitate the use of substances as a coping mechanism. And then, third, increase in use of one substance can sometimes lead to initiation of new substances, resulting in more complex cases of polysubstance use. And so we're concerned about a higher risk of alcohol and substance use problems in these settings. What kinds of services are being accessed to help address these problems? So a few years ago, our team conducted an analysis of UNHCR surveillance data that comprised 90 refugee camps across the world over a 5-year period. And the data showed the number of visits to refugee camp health centers for various types of mental, neurological, and substance use. So again, those MNS problems. And what we found was that in general, visits for MNS problems were very low. Individuals were rarely seeking or receiving services for MNS problems overall. But then looking within this pie of MNS visits by type, we found that the least common visit type by far was for alcohol and substance use problems. In fact, they accounted for only 1% of all MNS visits to refugee camp health centers. The visit rate that we calculated across all of these 90 camps for that 5-year period was 2 visits per 100,000 person months. And so imagine a 100,000 person population over a 1-month period, there would be on average 2 visits to health centers for a substance use issue. So basically, that's as close to zero as you can get for a visit rate. Essentially, no one in refugee camps was getting services for alcohol or substance use problems, right? This, despite the fact that, as we mentioned earlier, there is an increased risk for alcohol and substance use problems among populations affected by humanitarian emergencies. And so this strongly suggests pretty significant treatment gaps. And along those same lines, a couple of years back, with support from UNHCR, and subsequently, we published this in WHO Bulletin. Dr. Claire Green and I, my colleague in a lot of this work, who's at Columbia with me, did a big sort of desk review, scoping review, looking in the academic literature, in the grade literature, and international organization NGO websites on interventions for alcohol and substance use problems in humanitarian settings. And so we won't go into all the methods for this review. Suffice it to say again that we took a lot of time and searched through over 11,000 abstracts and websites. And from all of that searching, we found six interventions that were tested among refugees in camp settings. And so from the review, we had a few key findings that I just wanted to briefly share with you. And so the first key finding was, and this was sort of obvious, but we felt like it needed to be said directly, there is an extreme lack of focus in both the academic and the unpublished literature on refugee substance use prevention and treatment approaches, right? So that is something that we in global mental health need to address, and address rapidly, right? Given that even before the horrific situation in Ukraine, there were more people forcibly displaced worldwide than ever before, right? So this is an emergency. Our second key finding was that of the intervention studies and papers we identified, almost all were sort of low methodological quality studies. Mostly they were observational studies. There was only one properly powered randomized controlled trial, and that trial did not have a primary outcome of substance use. It was measured as a secondary outcome. There were also lots of measurement issues in these studies, which I'll come back to again at the very end of this presentation. Our third key finding was that most interventions we identified focused on preventing or treating unhealthy alcohol use only. Of course, a focus on alcohol in and of itself is not a limitation, right? It is the most common substance used globally. But the sheer lack of focus on other non-alcohol substances we did think was a pretty big concern. Our fourth key finding was that the so-called brief interventions were the most commonly used approach to addressing alcohol and substance use. And I'll be coming back to this in just a second as well, as there is some question about how effective these brief interventions can be on their own as a treatment approach. And then key finding 5 gets at that point a bit more, right? Brief interventions may not be appropriate for more severe alcohol and substance use disorders. And so our review highlighted that more intervention approaches are needed to address moderate or severe substance use disorder, as well as more complex cases of polysubstance use and mental health comorbidities. We were unable to find interventions tested or implemented in humanitarian settings that were really equipped to do that. Okay, and so what are these alcohol brief interventions that were the most commonly used in humanitarian settings that I just mentioned? So usually brief interventions are one single counseling session aimed at helping a person reduce their drinking. Brief interventions, or BIs as they're called, are meant to be delivered by non-mental health professionals. So oftentimes the goal is to embed them within something like primary care or existing health programs like HIV care, for example. So they can be delivered by, a nurse, by a primary care doctor, by a lay counselor, et cetera, but that person does not have to be a mental health professional. And so in principle, these seem pretty promising, but a number of studies on brief interventions so far in low and middle income countries have not really been very encouraging. So there were some well-done studies, one that I would highlight by Wandera and colleagues from Uganda, one by Peltzer and colleagues from South Africa, basically showed that alcohol brief interventions were no better than control conditions at reducing unhealthy alcohol use. Both of those studies were actually done among people living with HIV. And so it begs the question, right? Why? Why haven't these brief interventions worked as well as we would hope? So I would argue this, as I sort of alluded to already, right? Comorbidity tends to be the rule, not the exception. And this may be particularly true among humanitarian affected populations. Alcohol and other substance use, does not occur in a vacuum. Alcohol brief interventions are, even at their best, not equipped to address depression or anxiety or post-traumatic stress, et cetera. And so perhaps it shouldn't be surprising to us that they haven't been found to be effective in most cases if a person's problematic drinking is being driven by a comorbid mental health problem. And so for our team, an approach that we have used to try and address this challenge of comorbidity in low middle income countries and increasingly in humanitarian settings is called the Common Elements Treatment Approach, or CIDA for short. And so CIDA is a psychological intervention built as what's called a modular multi-problem program, also known as a transdiagnostic treatment approach, that has the ability to address multiple problems, right? So not just one, so a very wide range. Our counselors are trained to address symptoms of depression, of trauma, of anxiety, and of substance use using mostly cognitive behavioral therapy-based approaches. Like most of our interventions in global mental health, CIDA uses a task shifting approach and an apprenticeship model of training and supervision. It's delivered by lay counselors with very little or often no background in mental health. Our counselors are provided with what we call an element toolkit. And so they're trained to work with their clinical supervisors to choose appropriate evidence-based elements based on a specific client's needs and symptom presentation. So in that way, CIDA is very much so customizable and adaptable. And so the idea here with this transdiagnostic therapy is to, remove these treatment silos that can exist and equip one counselor, one provider with the ability to treat a range of potentially co-occurring problems, which we think makes the intervention more scalable in low resource settings. And so here you can just see the various evidence-based elements of CIDA, most of which are based, again, on cognitive behavioral therapy that the counselors have at their disposal. And again, they're trained to flexibly choose, which components in this wheel to deliver in a therapy session based on a particular client's symptoms, right? So, for example, behavioral activation could be chosen to help address a client's depression. Substance use intervention component could be used for clients who have unhealthy alcohol or other substance use. Again, CIDA is delivered by lay providers. Usually it's about between 6 and 12 sessions per client, but there is flexibility there depending on symptom severity, usually 45 to 90 minutes per session. The location of sessions is also flexible, which can be really important, obviously, in humanitarian settings. And so CIDA can be delivered in health clinics or community-based locations like churches. We've had it delivered under a tree, on a park bench, really anywhere a client feels comfortable. And we're actually currently testing the ability for CIDA to be delivered with efficacy and fidelity using telephone, or T-CIDA, as they're calling it. And we found that this flexibility really helps to reduce stigma and increase engagement in care. So CIDA has been tested in 7 randomized controlled trials across the world in low and middle income countries across a wide range of populations, and found to be effective for a range of problems, again, including depression, anxiety, PTSD, functional impairment, as well as unhealthy alcohol use. And these are just 3 of those trials you see on the screen. If you are interested in these papers, I'm happy to send them over. Just get in touch with me after the session. And so with CIDA, we believed we had a robust kind of lay counselor delivered intervention that has potential to address alcohol and substance use problems and mental health comorbidities in humanitarian settings, potentially, right? But a few years back, while working on an alcohol intervention project in Lusaka, which is the capital city of Zambia, again, which is in Southern Africa, working among an HIV affected population, we started thinking about developing a broader package of care that could address a wide spectrum of alcohol use problems, because not everyone will need between 6 and 12 sessions of the full CIDA intervention. And so you may have heard of what's called SBIRT, S-B-I-R-T, stands for Screening, Brief Intervention, and Referral to Treatment, as an intervention system for alcohol use problems. It's been found to be pretty effective in high-income countries, rarely tried or used in LMIC, not used at all in humanitarian settings to our knowledge. And the basic idea is that a person is screened for unhealthy alcohol use using a valid screening approach. If unhealthy alcohol use is indicated, they receive an on-the-spot brief intervention from a trained provider. And then for those with more severe problems, a referral to more robust treatment is made. Now, of course, as I mentioned earlier, these alcohol brief interventions by themselves may not be effective for a number of individuals, but as part of a treatment package, they could have utility. Now, for this package of care to be effective, it's obviously important that the brief intervention itself is theory-driven and evidence-based. And so the CIDA clinical team a few years ago developed an alcohol brief intervention based on the substance use reduction element that already existed within the full CIDA intervention, and called it the CIDA BI, the CIDA brief intervention. And so it is a multi-component BI, right? So there are elements within it of psychoeducation, of motivational interviewing, and of cognitive behavioral therapy, all of which are evidence-based for alcohol reduction. Just as with CIDA, the CIDA BI is deliverable by lay providers. And even though it is multi-component, it is one session. So it takes about 30 minutes or so to complete that one session. And so this is the package of care that we have tried to set up, right? An SBIRT, S-P-I-R-T model of a validated alcohol screening approach, provision of the CIDA brief intervention, which again is based on evidence-based elements, and then referral to CIDA for individuals with mental health comorbidities or substance use comorbidities. And this basically represents, right, a stepped care approach to alcohol and substance use. And so I don't have time really to go into details on this, but happy to answer more questions about it. And these are findings that are just out in a recent issue of AIDS and Behavior. But we conducted a randomized controlled trial that we did in Lusaka, Zambia, within HIV clinics. And in that trial, we tested this SBIRT package that included the CIDA brief intervention and the full version of CIDA. And our results were interesting, at least we thought so. So the main takeaways were that among people living with HIV who had unhealthy alcohol use, but who had no other mental health or substance use comorbidities, the brief intervention by itself was pretty effective in reducing unhealthy alcohol use. But for individuals who had one or more mental health or other substance use comorbidities, the brief intervention followed by CIDA was necessary to improve symptoms. And so these trial results basically supported our hypothesis that an SBIRT stepped care package where individuals receive a level of care, can measure it with their symptom severity or complexity, was effective in this HIV care setting. And so we think this shows sort of strong potential for an intervention approach that could be used more broadly in low resource settings. And so if you remember the review that I talked about earlier that underscored the gaps in addressing alcohol and substance use in humanitarian settings, in response to that, Claire Green and I at Columbia put together in collaboration with just a wonderful range of partners who you see on the screen here to basically take that SBIRT model, screening, brief intervention, referral to treatment model that we tested in Lusaka in the context of HIV clinics, right? The CIDA brief intervention and the full version of CIDA as a package of care to test how well that would work in addressing alcohol and substance use in a place called Montapala Refugee Settlement. And we were very fortunate to get this funded by the great UK-based organization ELRA and R2HC. And so Montapala Refugee Settlement is a humanitarian setting in an extremely remote place in northern Zambia, right across the border from Democratic Republic of the Congo. It's received a large number of refugees from DRC over the past 5 years or so. It's a really interesting, really inspiring place. I was just there like a week or two ago. And according to all the stakeholders that we talked to, addressing alcohol and substance use was a huge, but basically completely unmet priority. And so we are about a year into the study, and we'll be working on implementing and testing the SBIRT intervention starting later this year, which is very exciting. And the idea behind the study really is to try and address many of the gaps in the literature that we just highlighted, right? Including addressing both alcohol and other substance use, using validated measurement tools, and providing the SBIRT package of care for a range of severities. And we think that this is one of, if not the first randomized controlled trial in a refugee setting, testing an SBIRT package intervention with a primary outcome of alcohol and substance use. Unfortunately, the study, of course, is going on right now, and so I don't have results yet to share with you, but I guess it just means that CIRA will have to have another one of these symposia so we can present these findings in the coming years. And I will wrap up with this slide, but I did want to highlight what are sort of specific challenges for adapting alcohol and substance use interventions for humanitarian settings, because this is really, I think, where the brains and talents of people involved in this session could really be useful, right? And so one challenge that I think a lot about is measurement. With alcohol and substance use, we often run into measurement problems of underreporting, especially among populations where stigma is a challenge. We see a lot of social desirability in alcohol and substance use reporting, which makes the outcomes in our trials really difficult to measure. And there are contextual reasons for people in humanitarian settings to underreport using alcohol or other drugs as well, right? If those substances, if the use of those substances is prohibited in refugee camp or settlement settings, which it often is, it makes sense that people would not want to talk about the use of alcohol or drugs. We also see a lot of homebrewed alcohol. In Montepala, where we just were, they described like, I think 10 to 12 different varieties of homebrews, each with differing alcohol content, from one batch to the next. And quantifying that for purposes of research and clinical trials is a huge challenge, honestly. Chronicity, substance use problems are chronic diseases. We need to remember that even with effective treatment, recurrence of a substance use disorder among someone who has true substance dependence can be like 50%. And so how do we set up programs and systems in humanitarian settings that are equipped and prepared for that sort of recurrence over time? And then related to that, systems of care. So the SBIRT that we described is a system of care, right? And the last part of it, the referral to treatment part, in our case means referral to CIDA, but is CIDA as a, sort of laid counselor delivered psychological intervention, is it equipped to address someone who has severe opioid use disorder, who has physical dependence? No, by itself it isn't, but medication for opioid use disorder is not readily available in LMIC and in humanitarian settings especially. And so figuring out the top of that treatment pyramid really remains an incredibly difficult challenge for substance use. And so no easy answers here, but I can't emphasize enough, just really important that we as a field try and address them, given the high prevalence and burden of substance use problems in humanitarian settings. And so we'll wrap up really with the slide, just to say very grateful to an amazing group of collaborators around the world, especially in Zambia, and for funding from NIH, who funded our trial work in Lusaka among HIV-affected populations, and once again, ELRA and R2HC, who are generously funding our work in Montepala that we are so excited about. And I will stop there and just say thanks again, Luke, and to CIRA and Yale for the invitation, and looking forward to your thoughts and questions.
Thank you so much, Jeremy. Tremendous presentation. And I think there's a lot to chat with you about when we get through with the second presentation. I see there's some questions coming through already, and so I appreciate others taking advantage of that as well. I'll move ahead now to introduce Dr. Kelly O'Loughlin. Dr. O'Loughlin is an assistant professor in the Departments of Emergency Medicine and Global Health at the University of Washington. She is a global health research scientist focused on assessing the needs for health for refugee populations and on designing and evaluating refugee-specific interventions to improve care. She has been working to optimize HIV care engagement in Nachavali refugee settlement in Uganda for over a decade, funded by the National Institutes of Mental Health. Dr. O'Loughlin also investigates assisted partner notification for HIV among refugees in the West Nile region of Uganda, with funding from the University of Washington, Fred Hutchinson Cancer Center for AIDS research, and the impact of movement on HIV research engagement for refugees across Uganda, also with funding from the UW CFAR. Recently, Dr. O'Loughlin began COVID-19 research among vulnerable people accessing emergency medical care in the United States, and she's interested in investigating interactive voice response, telephone-based COVID-19 symptom and exposure surveillance tool among refugees in Uganda. And that work is funded again by the ELRA organization that Jeremy mentioned. So I'll turn it over now to Dr. O'Loughlin. Thank you so much for joining us today.
Thank you, Luke, and thank you to the symposium leaders for this wonderful opportunity. And I really appreciated hearing about your work, Jeremy, and about the excellent methodologic approach you're taking. It's really inspiring. So today I'm going to be talking about optimizing HIV care engagement for refugees in Uganda. And I am grateful for the support from the National Institute of Mental Health, as well as for funding through the NIH and NIAID to the Center for AIDS Research at my local institution. So first, I'm going to dive in by talking about the background, refugees, HIV, and specifically where I've spent a lot of time in Nachavali refugee settlement. Refugees face hardships, which may increase their vulnerability to HIV compared to non-displaced populations. Hardships faced by refugees include difficulties meeting basic needs, disrupted social networks, limited livelihood opportunities, threats to security, prolonged displacement, exposure to sexual violence and transactional sex, and difficulty accessing condoms and sexually transmitted infection treatment. And I want to point out from the outset that refugees are inherently mobile. Just by the definition, a refugee is a person who has fled war, violence, conflict, or persecution and has crossed an international border to find safety in another country. Well, it's not just that initial fleeing. Many refugees continue to move after their initial period of displacement for a variety of reasons, including accessing basic necessities, pursuing educational opportunities, seeking livelihood opportunities, visiting family and friends, attending events like weddings and funerals, and also just integrating with the local community. And there's a growing recognition that refugees' mobility is a positive asset that can contribute to their lasting protection. And I hope that we can move forward with that understanding, that the medical, policy, and research community have to collaborate to understand the implications of mobility on movement in the context of HIV and other medical conditions, to enable refugees to engage in a care that is acceptable to them and in a way which optimizes their health. Now I want to focus on the location where I've been conducting a number of refugee-focused research studies over the last decade, and that's the country of Uganda. Uganda is in East Africa, and it's unique for my work because it hosts approximately 1.6 million refugees. Narrowing in on Nachavali refugee settlement, which is located in southwestern Uganda. The site was established in 1960 and is approximately 71 square miles and hosts a population of about 150 people. The majority of the refugees in Nachavali are from the Democratic Republic of the Congo, Burundi, Somalia, and Rwanda. And additionally, there are Ugandan nationals that live in and around the settlement and that access services there. There are 4 health clinics in Nachavali, which serve refugees and Ugandan nationals and provide free HIV testing and antiretroviral therapy. And the HIV prevalence from the refugees' countries of origin range from 0.5 to 6.1%. The routine HIV testing studies that our team conducted in Nachavali showed a prevalence in this location of 4.5%. And we know that the surrounding prevalence of HIV in this area of Uganda is about 7.3%. I'm now going to tell you about research that our refugee-focused team has conducted in Nachavali related to understanding and optimizing HIV care engagement. Our research team is conducted in partnership and with leaders from the United Nations High Commissioner for Refugees, Medical Teams International, Infectious Diseases Institute at Makerere University. And our work is informed and greatly benefits from a community advisory board, which consists of refugees, including some living with HIV that live in the refugee settlement. The first study I want to tell you about was on the HIV cascade of care in Nachavali refugee settlement. Our team conducted this study in 2013 to assess the cascade of HIV care among refugees and Ugandan nationals in Nachavali. And in this study, 6,850 individuals that were participating in routine clinic-based HIV testing were tested for HIV and enrolled at the time of testing. And we found 276 of them to have HIV, that was 4%. And we then followed them forward to see of those people, how many people linked to one of the 4 health clinic centers in this large refugee settlement. And we found that only 54% of them linked to HIV clinical care within 90 days of diagnosis. And as I said, despite the fact that care is free for them. So antiretroviral therapies are available and available for free, but when we looked at the records, we could only find 54%. This highlighted the need to investigate linkage to HIV care in the refugee settlement, as well as opportunities to enhance HIV care engagement. So our team conducted a follow-up qualitative study in Nachavali to understand barriers to HIV care and potential approaches to overcome them. We enrolled participants after HIV testing and invited them to interview with us 90 days after their new diagnosis, and we conducted semi-structured interviews with 54 clients and 8 health worker staff to assess the participants' experiences accessing HIV clinical care. From these interviews, we learned that refugees living with HIV face daily challenges that are barriers to engagement in HIV care. including food shortages, problems maintaining shelter, health needs, difficulty accessing potable water, limited childcare, difficulty with transportation, and limited emotional support. And for some individuals, especially those able and willing to disclose their HIV status to others, they were able to benefit from social support, allowing them to overcome these daily challenges and successfully engage in care. But for others, particularly those with anticipated stigma, PTSD, depression, and anxiety, they often defaulted to non-disclosure. And by not sharing their HIV status, they often remained isolated and unable to benefit from the social support of others and faced more difficulties successfully engaging in HIV care. And that was a qualitative study that we published in AIDS and Behavior. Equipped with this information, we then began a study to enroll a cohort of people newly diagnosed with HIV in the same setting in Nachavali refugee settlement to assess which factors correlate quantitatively with failure to link to HIV clinical care. For this study, there were 3 enrollment sites in Nachavali, Juru, and Chibango health centers. Adults accessing routine HIV testing were invited to participate, and this included refugees and Ugandan nationals. We surveyed participants prior to testing to evaluate their demographic information, perceived health, HIV testing history, distance to clinic, time living in Nachavali, and travel history. We also used validated surveys to screen for depression, generalized anxiety disorder, PTSD, social support, and stigma. For this study, we enrolled 5,568 individuals at the time of HIV testing. 65% of those people were refugees and 34% were Ugandan nationals. Of the 5,568 tested, we found 219 to be diagnosed with HIV. That was 3.9%. And comparing HIV positive and HIV negative participants, those diagnosed with HIV were more likely to be female, Ugandan, and to screen positive for PTSD. And those with HIV were less likely to be living with a partner and to self-report being in good health. Health status, health limitations, prior testing, distance to clinic, none of those indicators were associated with linkage to care. In evaluating the cohorts of individuals newly diagnosed with HIV, as well as the associated variables, screening positive by this survey, again, not a clinical diagnosis, but a screening tool, looking at screening positive for PTSD, depression, anxiety, social support, as well as anticipated stigma, and looking at the association with linkage to HIV clinical care, the only significant finding was the presence of social support. So those who had more social support were more likely to link to HIV clinical care. These findings demonstrating the importance of social support with HIV care engagement in the refugee settlement motivated our subsequent research. And now I want to share with you our current research related to enhancing HIV care engagement in refugees in Nachavali and elsewhere in Uganda. So given the findings of poor linkage to care after a new diagnosis, as well as social support importance, our team sought to pilot an intervention designed to optimize linkage and retention in HIV care in Nachavali. And this study is funded by the National Institute of Mental Health through a K-23. And first, it's imperative to understand that differentiated ART delivery is a part of the Ministry of Health's care delivery approach in Uganda. So differentiated antiretroviral therapy delivery is an important client-centered approach that simplifies and adapts HIV services to meet the needs of individuals living with HIV while reducing burdens on the health systems. Community ART delivery is one beneficial differentiated ART delivery model that is presently available in Uganda for stable clients. What is a stable client? The Ugandan Ministry of Health defines stable in HIV care as being on meds for more than or equal to 1 year without treatment change, adhering more than 95% of the time, not pregnant or breastfeeding, on one of the first or second line regimens, not currently with an acute illness or concurrent illness, and with a suppressed viral load defined as less than 1,000 copies per milliliter. And there are many recognized multi-level benefits of community art delivery care, again, which is only available for stable clients. At the individual level, it enhances accessibility to art, provides psychosocial peer support, lends autonomy, decreases perceived stigma, facilitates retention, improves viral suppression. At the clinic level, it helps decompress HIV client volume, decreases the workload of clinic staff through some task shifting, and at the societal level, decreases community level stigma and decreases HIV transmission. So now I want to tell you about our intervention, which we called early community client-led art delivery, or early CCLAD. And as demonstrated in the figure on this slide, our intervention is an expansion of an existing community art delivery model already in place in Nachavali for stable clients. This program is called, the normal program is called Community Client-Led Art Delivery, and our intervention offers the same intervention, but instead of waiting till they're stable in care and meet all those criteria that we talked about, it is provided to people newly diagnosed with HIV. And let me tell you a little bit more about what this intervention is, both for us providing it early, but also for stable people, how it already looks. So a description of the intervention is that newly diagnosed clients, or in stable care, people who are already diagnosed, they're placed into groups of 3 to 12 based on geography. Their first meetings held at the health clinic with HIV counselors, and their subsequent meetings are in the community. And for the purposes of early CCLAD, these were conducted monthly. One group member, varying each month, goes to clinic, attends clinic prior to the group meeting, and picks up the antiretroviral therapy for all the group members. And then they return, meet with the group, and distribute the art to the group. So each client in this model only needs to attend HIV clinic twice yearly, and that's for a comprehensive clinical exam and laboratory testing. Though they're always invited to attend if they need to, or if they feel like they need an evaluation. And there's liberty of the HIV clinic staff to make recommendations regarding that attendance. The outcomes of this study that we looked at included meeting or HIV clinic attendance, viral loads, as well as baseline and then 6-month follow-up mental health and social support outcomes. So in this study period, 2,793 people were tested for HIV and 92% were found to be HIV positive. That was a 3.3% prevalence. And so from that, we ended up with a cohort of early CCLAD participants of 31, and that was of the 92. So here we just want to demonstrate to you the difference between the people who participated and the people who didn't, though this is in no way a comparison because this is a pilot study and that was not a random sampling. But the early CCLAD participants were a bit older, less female, less often refugee. And the most important thing to point out here is that even in those who did not participate, 70% were willing to participate. But the barrier that our team faced in placing them was with this huge geographic land. It was really hard to get people that lived close to one another to put into groups in time. And so the main barrier to getting everyone in was this geography, because we only had 90 days before that they would not be eligible. So of our 31 participants in this cohort, at baseline, again, we screened for these mental health conditions. And we found that 48% had screened in for anxiety and depression, 16% for low social support, and 65% for PTSD. And of the people asked about their health status, it was pretty much split 50-50 about those reporting poor health versus those reporting good health or very good health. 100% of those put into early CCLAD were initiated on art. And then we tracked the amount of early CCLAD visits they attended in the first 6 months, and it ranged from 0 to 7 with a median of 3. And we also looked at if you counted early CCLAD and HIV clinic visits in the first 6 months, and this was a bit higher, 1 to 8 with a median of 5. And then important, we really wanted to know if there was, kind of getting a signal on the impact of viral load at 6 months. And we found that 20 of those tested. So unfortunately, we have 23 tested of the 31. So of those tested, of the whole 31, 64% were virally suppressed and almost 10% were unsuppressed. But again, probably a more accurate number would be, and in some analyses, and we'll probably have to do this for our final analysis, but basically we need to impute of the missing data, what's the likelihood that they were suppressed. And so I think more accurate would be to look at, of the 23 that tested, there were 20 that suppressed. We also, again, looked at 6-month follow-up survey to relook at these mental health indicators. Now, as I said, there's 31 in the cohort. So this was the baseline data I already showed to you in dark gray. However, only 21 completed the 6-month follow-up survey. So taking those exact same 21 individuals and comparing their baseline survey to the 6-month survey on this slide, we see that for those 21, the proportion screening in for anxiety decreased from 42.9 to 28.6. Screening for depression decreased from 47.6 to 19.1. For low social support, changed by half. PTSD also decreased from 57% to 42.9%. And then generally the health status improved over time. So after reviewing these preliminary results, I'm convinced, first of all, actually, I want to share the benefits of the intervention we also got to learn about through exit interviews. These included reduced transport costs, easier access to art, enhanced adherence, less HIV status closure, peer support, and reduced stress. One participant noted, when I joined the group, I saw I'm not alone. We're like one family sharing challenges as a family. And another explained, for the first time, it's hard for the person to feel comfortable with the results as HIV positive. But after joining the group, life became easy. So after reviewing these results, I'm convinced we should proceed beyond this pilot to assess the efficacy of this intervention. And I'm currently working on an R1 to look at a community-based art delivery intervention that will include both newly diagnosed clients as well as those unstable in care. And I'm hopeful to have the opportunity to conduct this research. And briefly, I just want to tell you about one study that is underway now called Art on the Go, funded through CIRA, through the NIH, NIAID. The goal of this study is to understand what aspects of refugees' movements are associated with care engagement, defined as linkage to care, retention in care, adherence, and viral suppression. And similar to the early CCLAD, the overarching goal is to inform interventions that can optimize HIV care for refugees, especially acknowledging their mobility. So for this study, it's a prospective study enrolling a longitudinal cohort of those newly diagnosed and those already in care, both in southwestern and northern Ugandan refugee settlements. This includes adults in 9 languages, and we're looking at characteristics of travel, and we're using an interactive voice response technology. An interactive voice response basically allows you to push the buttons on the keypad and hear a response on the other line. So to date, we've enrolled 627 participants, and we'll follow these people with monthly surveys for the next 5 months and look at their HIV clinic data. To conclude, refugee-centered interventions are needed to optimize care engagement for this unique population. Opportunities to foster social support for refugees may improve care engagement, and characteristics of mobility and the impact on care engagement should be considered for differentiated HIV care programs for refugees. And finally, community-based art delivery for refugees may help overcome geographic and cost barriers to clinic, as well as lend psychosocial support, resulting in improved HIV clinical outcomes. Some acknowledgements to important colleagues and collaborators, and thank you, and open it up for questions.
Thanks so much, Dr. Olafin. That was a really superb presentation, and we'll now open the floor for questions. I already see there's a few things that have been put into the chat, and so maybe I'll start with this first, I think, broad question that both Jeremy and then Kelly could, I think, address. The specific question is, I wonder if the panelists could speak on the ethical components and their thoughts on running and prioritizing RCT evaluation designs in humanitarian settings, particularly where people may not get needed services. And also feel free to comment on any other ethical issues. I know it's a big part of working with populations who are vulnerable, such as those that you're working with. Thanks. Jeremy, maybe you would take it first, and then we'll go to Kelly after that.
Yeah. Thanks, Luke. Thanks for the question. A really important question. Sort of fundamental. I would say I think that for RCTs to be ethical, of course, the first thing is they have to meet that criterion of equipoise, right? So there must be in any RCT, right, sufficient certainty that the test treatment could be beneficial to administer it to some individuals, while sufficient doubt exists about its benefits to withhold it from others. And so, in our case with CETA, with the ESPER package, our preliminary findings in Lusaka were promising, but not definitive, right? They were suggestive. And so I think we do meet that equipoise criterion. But it's true in refugee camps and humanitarian settings, obviously there are additional considerations, right? First we have to ensure that we are not disrupting ongoing services in any way. That's absolutely fundamental, I think. And you saw on the screen that I shared for this project, I think we have at least 10 different partners for this project, including 2 government ministries, several Zambia universities, several Zambian NGOs. And in large part, that is to help us to ensure that there is no disruption to ongoing services, because that's sort of the last thing that we would want to do by having a new research study in that sort of very vulnerable setting. And the second thing I would say is, we, meaning like our team, we always have a principle of providing the intervention to all of our control participants when they exit the study. I think not everyone does that, but we always do. So after they complete their final research assessment, all of the participants in our study will be offered CETA if they want it. But there is, the big ethical question does come in about how long is it ethical for them to wait, right? And so in the meantime, they're going to be getting treatment as usual in our trial, which, in Montepala refugee settlement means basically they can get some basic counseling at the health clinic. If they have really severe sort of alcohol withdrawal symptoms at some point, there is a local referral hospital. It's like an hour away, but the availability of medication and services there is very, very limited. So what our control participants are going to be getting during the trial itself is not very much, honestly. And that's just what the standard of care is currently, right? That is what it is. And so it is a principle of ours to be able to provide them with the intervention after the trial is over. But is it ethical for them to wait 6 months? Is it ethical for them to wait, 3 months, 12 months? And different people, I think, could make different arguments about that. But that is something we grapple with a lot. And it's also one of the reasons that we will have an independent data safety monitoring board for the trial to help us kind of figure out what is the most ethical approach. But it's a great question and something that we think about a lot whenever we do trials. And ultimately, a trial shouldn't be done unless it's really the only way to truly measure how effective an intervention is in a specific situation or setting. And I think that is the case for us here, but it is tricky for sure.
And to add to that, sometimes the intervention is too expensive or to actually do to everybody, especially if you don't know if it works. The design that I'm proposing for the R01 for the community art delivery is actually going to be a randomized cluster design, and there will be 12 health facilities matched with pairs, and then the intervention will be selected for one of the sites and not the other site. Because another problem that we run into is if a bunch of people are diagnosed with HIV in a time period and some people get an intervention and others don't from the same setting, that doesn't go well either with the implementing partners or the people living there, of course. So in that way, it seems a bit more ethical at the sites for this specific research.
Yeah, thanks for highlighting those issues. And I'll just briefly mention, we'll say more at the end, but we're going to be offering a workshop on ethical considerations for HIV research in humanitarian settings that many of the attendees may be interested in. So we have some.
Luke, sorry, I was going to say, if we can skip it too if there's other questions, but for substance use especially, it might be important to include stuff like that because substance use research also has other ethical challenges to it, obviously in refugee settings. And I just wanted to add that it has to be done really carefully as well, because as I mentioned briefly in the talk, most times drug use is prohibited. Sometimes alcohol use is prohibited in refugee settlements and refugee camp settings. And so, you have to be very careful when you're asking people about their use of alcohol and substance use and providing them interventions for that, because not only can it be really stigmatizing, but we don't want to get people into trouble, for example. And so figuring out the best way to do that is really important, which again is why having so many local partners involved in the project, I think, is really important.
Yeah, great point, Jeremy. So go back to Kelly for a question coming in from one of the audience members that sort of speaks to to what degree the strategies that you're using are focusing on people newly diagnosed with HIV versus people re-engaging in care. I think you mentioned that a little bit at the end. Could you just comment on that question and how it impacts the overall impact of your interventions? Thanks.
Yes, thanks, Marguerite, for that great question. Yes, definitely a lot of the people newly diagnosed aren't necessarily newly diagnosed, they're just newly diagnosed in our setting. For the purposes of the research, when we found them already in care in HIV clinic, we took care of that in the analysis. But I actually think that the bigger point is probably that maybe we should lump them together. Like if they're not, it doesn't really matter, really, does it? If they're newly diagnosed or not, they just need help engaging in care. And maybe it's for the same issue. Maybe it's geography, maybe it's stigma. And that's why for my next R1, I'm hoping the reviewers will allow me to lump them together. So we'll see how that goes.
Yeah, I mean, Kelly, I guess to what degree are the services that you're providing in the community simply shifting these services to the community versus providing new services that aren't already present at the clinic? Could you just comment a little bit on that?
Right. So like I said, this is really already the community art delivery groups are already happening. They're set up in the community. They're just not available for people that are unstable or newly diagnosed. And I think the whole point is with differentiated care delivery, we're trying to meet the client where their needs are. And probably all the people would benefit from accessibility of those proven interventions that are really working well for stable clients. And that's what I want to evaluate. Can we take the risk and allow people that are unstable or newly diagnosed to try this intervention? Because what if it gives them all the psychosocial support they need from the very beginning or in the middle to engage in care successfully?
Great, thank you. So Jeremy, you're sort of responding a little bit to a question coming in from Kave, which asks a little bit about the types of substances are being used and whether self-medication, to what degree that's, I think you mentioned that's often a strategy for coping with the types of stresses that many individuals may be experiencing because of their health and because of the displacement that they've experienced. Are there any positive aspects, Kave is asking, that we should consider about this, and how does that impact the way that your brief and more in-depth interventions work?
I saw that question and I was trying to think about any positive aspects to it, but I can't. Maybe Kave, if you want to chime in about what you're thinking there. What I was referring to really, is a very unhealthy coping mechanism, right, for dealing with trauma, for dealing with the stress of being displaced and potential violence people have experienced, and so really. And so it raises the risk for things like depression, for feeling anxious, for having post-traumatic stress symptoms. As we mentioned, there are often no mental health services in humanitarian settings, even for mental health problems, right? And so as a coping mechanism, because we don't have mental health services, people turn to drinking or to using other substances. And maybe they don't feel as depressed when they use a substance or when they drink. And so that really is kind of the crux of the coping mechanism sort of pathway to alcohol and substance use problems. But I can't off the top of my head think of a positive aspect of that, but maybe Kave wants to clarify the question.
Well, yeah, I think you pretty much answered. I just feel like we need to understand better this self-medication, how it works, etc. I just haven't seen a lot of literature on this topic. As you said, many of these individuals don't have access to mental health services. So they are kind of trying to manage it themselves. And some of that is through self-medication. And it is when I say self-medication, I'm sure there's a very broad range from prescription medications that they're getting from somebody to cigarettes, tobacco use, to alcohol use, etc. So I just feel like this is a topic we need to understand better.
Yeah, agreed. And I would say one thing that just crossed my mind through our qualitative work that we've done so far in Antapala and in Lusaka, actually one of the biggest reasons people give for initiating substance use or alcohol use or intensifying their use of it is boredom. And so you think about in humanitarian settings, that might not be the first thing that crosses your mind, is that people will be bored, but it could be, right? If people don't have work and don't have the regular things that they would be doing otherwise, they might just be kind of sitting around, and then which can lead to boredom, which in their own words can lead to alcohol and substance use problems. So.
Well, thanks so much for the engagement, and I can see that it's sort of continuing in the chat. I think we'll stop now so everybody has a moment to stand up and stretch your legs and take a break before we get back to the next session. But I just really want to thank Jeremy and Kelly for responding with your work to many of the gaps in the literature that I think were highlighted in the earlier talks that Holly and Blythe gave, and for really showing us that you can do rigorous work, develop interventions, and think about how to advance the science and also help the individuals there. And I know in the next session, as we engage with some of the types of partners that you guys have engaged with as well, practitioners, service providers, and community members, we'll have a chance to learn more about the role of research and care alongside one another. So just invite a round of applause for Kelly and Jeremy. It is 10:40 on my clock on East Coast time, so you can adjust to your time zone. But if you could try to come back in about 5 minutes, we'll get started with that next session.
5 a.m. Eastern, and our third session will be a dialogue with practitioners, service providers, and community members, and will be moderated by Dr. Kaveh Kusnud.
Thank you so much, Tini. And again, thank you for wonderful presentations. So we want to switch from kind of a research perspective to a practitioner's perspective. And I'm delighted to introduce you to 3 of our panelists today. One is Dr. Annamalai, the medical director of the Yale Adult Refugee Clinic that partners with local refugee resettlement agencies to provide comprehensive health screening and longitudinal care for newly arrived refugees right here in New Haven, Connecticut. She has been working with refugee populations for the last decade as both an internist and psychiatrist providing primary care and mental health services. Dr. Annamalai has received several awards recognizing her service to this population. She's the editor of Refugee Healthcare, a reference book currently in its 2nd edition used by clinicians caring for refugees. Our next speaker is Farishta Ganjavi, a former Afghan refugee, community advocate, public speaker, and founder and executive director of Elena's Light, which is a nonprofit organization in Connecticut that cares for refugees. Additionally, she works at the Refugee Council of the United States. Her passion lies in empowering refugee families through health education, personalized ESL tutoring, and cultural community exchange program. Her ultimate goal is to advocate for education, insurance, and employment rights for everyone, regardless of their immigration status. And our final panelist from Integrated Refugee and Immigrant Services, known as IRIS in New Haven. Sharon is a social worker in the intensive case management program at IRIS in New Haven. She has her bachelor's degree in journalism and a master's in social work, and is licensed in New York and Connecticut. Prior to joining IRIS in 2018, Sharon worked as a family social worker in New York City, providing case management and counseling to clients with substance abuse and mental health concerns. Thank you all for joining us. I'll turn it over to Dr. Annamalai and Farishta next, and Sharon, our final speaker. Thank you.
Good morning, everyone. Let me just quickly share the very few slides that I have. Okay, so Kaveh already sort of told you who I am and what I do. So I'm an internist and a psychiatrist, and I've been seeing refugees who come to the New Haven area for more than 10 years now. So I know we're not talking just about refugees today. This is about people in humanitarian settings, but refugees that are resettled are the population that I work with. So just like a 30-second overview on like who we see and how they get to us. So, refugees, when they basically, are created by whatever conflict is happening, they go through usually the United Nations Health Commissioner for Refugees. And once they're registered as refugees, the goal is always to try to send them back to the country they came from, if it's safe, or to house them where they're there. Like, for example, now people have gone from Ukraine to Poland and many places in Europe. Resettlement to a third country would only be if, it's not viable for them to stay where they are or they cannot go back. And then once it's decided that they're eligible for resettlement, then they have to go through multiple layers of clearance, both security and also health clearances. I mean, they're one of the most, I always say they're one of the most vetted migrant groups health-wise that come into the country. And then after these multiple layers of medical screening, they come to one of the resettlement agencies, and you heard that Sharon Weiss from IRIS is here. That's our local resettlement agencies in New Haven, and they help refugees through multiple facets of the resettlement process, and health is just one of the many things that they have to work on. And we work with the health coordinator from IRIS to make that happen. So that's how they come to us. And just very briefly, Connecticut being a relatively small state, and I know today the audience is from lots of different places, not just local, but we don't see the maximum number of refugees. The US map shown here shows states in blue, which are, in terms of just sheer numbers, the top 10 states that resettle refugees. And it's just because of various factors. Connecticut, I would say, when I started doing this work, I would say it gets typically like between 500 to 600 refugees, which is much less than some other states. But some years, like when the Syrian crisis really exploded, 2016, we got close to 1,000 refugees. And now this past year, we got several hundred Afghan evacuees. So it kind of varies, obviously, depending on what's happening. But generally, to give you a sense of where Connecticut stands. And again, where we get people from, even all over the world, depending on where the conflict is happening. But, they do tend to resettle people where there's already a group there. So we have tended to get people from the Middle East a lot. And then we've gotten a lot of Afghans in the last few years, not just last year, even before that. And of course, we get people from Africa and other parts of the world. That's not been the predominant population in the greater New Haven area, though we, even in Hartford, actually, they get more Congolese, for example. But again, just locally within our region, that's who we see. And then one point also to note is because they come through a formal resettlement program to our clinic, they actually do have for the most part, they do have access to healthcare temporarily. It's not a long-term, lifelong access, but for the first 8 or 9 months, they can access what's called the refugee medical assistance, which in most states translates into the local state health insurance. And I just point this out to say that this is a little different from people who may be fleeing other situations, who are coming through the southern border, for example, and who may not be documented, and they may not even have this access. But if they're coming through a formal resettlement program, then they at least have some initial access to healthcare. And they could be seen by anybody, but typically it ends up being hospital-based or academic centers and university-based clinics that tend to see them, for various reasons that just works out better. So our program, we have an adult clinic and a pediatric clinic. I run the adult clinic, and this is just, some of us, me talking to some residents. And our clinic is actually staffed primarily by trainees. It's internal medicine residents, and we've had psychiatry residents and fellows also work with us. And it's based within one of the primary care clinics in town. But it's run by the residents, myself, and sometimes we have other faculty helping us. And then we have, sort of the usual clinic structure with a nursing staff. And then we always have the health coordinator from the resettlement agency as part of our team. And I already mentioned IRIS is who we work very closely with. So pretty much anybody that comes through IRIS through their resettlement pathway comes to us for their initial healthcare. And then our goal is to then establish them. We sort of do their initial health assessment. So we see them for like their very first assessment in New Haven, and then we plug them into our health system. So we serve as sort of the gateway for them to get established in healthcare here. So beyond the clinical services, we, like I said, we had trainees. We also have students who sometimes spend time with us. We do didactics, hoping to increase awareness of who these people are coming from this humanitarian crisis. And so for trainees to learn, a little bit about culturally providing appropriate care. We also serve as a hub for education and training for other Connecticut agencies that are also trying to see new refugees who are maybe more new than we are to this population and how to provide care. Just in terms of what we see, I know I caught, and I'm sorry I was not there for the entire morning's discussion, but I caught a little bit of the end where you were talking about, I think, mental health and substance use. So typically, the things that are most studied for better or for worse in this population are, trauma-related disorders and depression. In terms of substance use, I was just hearing Kaveh saying, we need to study that more. And I think that's definitely true. We need to look into that more. I can say that anecdotally, and also what's published within the refugee literature, there's actually not that much known about how prevalent these disorders are. I can say anecdotally from what I see in clinic, tobacco use is highly prevalent, and alcohol use sometimes, but I would say that's really not what we predominantly see. And other substances, occasionally they would already have been on prescribed benzodiazepines like Valium, but typically that's not the predominant thing we see. And I heard Kaveh, talking about self-medication. And I think what we see more commonly rather than people self-medicating with either prescription or illegal drugs is people having a lot of sort of somatic physical symptoms from their mental health distress and seeking help for that. That is what I would say we see much more commonly. And I think that's kind of borne out in the literature too, not just our anecdotal experience. And then, I think, we talk about HIV a lot and we should, but we do see actually a lot of chronic health diseases like we see in the rest of the world. People are coming with more and more hypertension and cholesterol problems and definitely dental problems. Even at age 20 or 30, they've had a lot of dental issues. So that's kind of what we see a lot. And we do see latent tuberculosis, typically not active tuberculosis, because again, they've been screened and vetted for this. But just to give you a sense of sort of what we see, which is really not sometimes what people might think primarily as, communicable diseases, but we really see a lot of other things. So I'm going to stop there. These are just some partners who we work with and who help us do this work. So I just wanted it to be a very brief introduction to what we do. So I'll stop sharing here and turn it over to the other panelists.
Thank you so much, Dr. Annamalai. I will turn it over to Ferishte Ganjavi.
Hello, everyone. Thank you so much for inviting me to this panel. I'm so excited. I have a very short presentation. I promise it's not going to take more than 5 minutes. I would like to share that with you. And let me share my screen. Okay. Yeah, this is Ferishte Ganjavi. I'm founder and director of Elena's Light. I'm former refugee myself. I came to this road from the beginning, applied application through the UN, came to the US on a long way. I know all of the circumstances and situation. That's why I try to create a platform, a thing that can help the other refugee like myself better. These are all the friends and community who support me at this area. Elena's Light is a local organization in Connecticut. We are working to help build brighter future for refugee women and children. Here is some of the picture and the vision as well. Why we choosing women and children to work? Because refugee women and children do not have same equality and access to the mental health and healthcare behavioral access compared to the men. Also, there is a lot of other barriers like cultural, language, financial situation. Also, the women we have, they don't have access to the practical and educational things that other gender may have. Cultural, family situation and logistical barrier prevent them to get this education or seeking to the access to education or the health or the mental health services that they need. This is like overall 3 things that Eleanor's like providing, but I'm going to talk more today about the health part. First of all, we are doing personalized ESL and permit, and also getting the driving license and citizenship for women. The health part, we have different research and different programs that I'm going to talk about it more. Also, we have a lot of community engagement that can help the community to receiving services that they need, especially this community service more get highlighted during the COVID. These are some pictures that which I really miss. I hope this COVID situation get much better soon and I can have this in-person meeting with the families. I thought it would be good to share these beautiful pictures with you and see a different culture from an Afghan family. This is the inside of refugees families. And as I told you, we are working with various group and organization and hospitals around here to create some program, which would be a research as well, and serving and supporting our community. One of them was the COVID research that we did, and also we had a program. One of the person who did the study with us, did this research with us was, his name is Joseph William, and he is a master student from School of Public Health. If you want to hear more about his research, you can scan this barcode and go, but I'm excited to be part of this important work with him. This is overall what he found out after doing this research and the program with Eleanor's Light families during the COVID. Nutrition, depression, and development was the 3 main things that he found out about them. These are the 2 quotes I thought would be good to share with you. Some of the families, they were concerned during the COVID, their kids seems very smaller, they were kind of not eating that much well, and they were kind of a little, it wasn't a good situation, as I know many of you may have experienced in your own life. It wasn't a really good time for everyone to be all the time at home. The second program I would love to highlight that we do is the Empower program. It's our children's summer wellness program, which we did it during the exactly COVID summer when we had it in 2020. You can also copy the barcode if you would like to go and hear more about it. It had a very great outcomes and researchers, and also benefit for the community. Empower stands for Emotional Program Outside the Clinic with Wellness Education for Refugees. This is some of the pictures that we had from that program and some of the game and playing we did with the kids during that time. Here is the other program. We are working with the women's health classes that we have with Y Healer, and also community and members in the community who are willing to teach our women. Once a month during the now time, we are teaching these classes. It's all is related to the mental health, health behavior, and family training, helping them for the parenting classes. We'll make sure 5 to 10 women at least join the session, and they will receive gift cards as to say thank you for participating. You can also scan the barcode if you want to hear more about it. Sorry, I'm trying to be very quick. These are all the group, and it's some of the group that we're working with them, and a great organization. We are so happy and proud to have all of them working with us. Some of them are local and some of them are international. If you like to contact us, again, you can copy the barcode, and also my emails and the other colleagues' email are here. feel free to send us email, or if you have any question, you can ask there too. And this is our also other page for the social media. And thank you so much. I hope I promise my time. If you have any questions, please let me know. I want to see how I can.
Thank you, Tricia. Really appreciate that. Our final panelist is Sharon Wise from IRIS. Sharon?
Good morning. How are you? I thank you to my co-panelists. I appreciate being here with both of you. And I do not have a slide presentation, but I'm going to give you a description of what I do at IRIS and our program there and how it affects the clients that we work with and in the humanitarian setting that within which we provide services. I want to start out with just a few acronyms because Symposium would not be complete without a few acronyms, some of which you may know and some of which you may not be as familiar with. The first is ORR, and that stands for the Office of Refugee Resettlement, and that's an office within the Federal Department of Health and Human Services. And many of the grants at IRIS come from ORR, and they can only be spent on working with ORR eligible clients, which include refugees, SIVs, Cuban and Haitian entrants, Amerasians, and victims of trafficking. And we can work with those clients from day 1 through year 5. And then the second acronym is CWS, which stands for Church World Service. There are 9 national refugee resettlement agencies in the United States. Local agencies like IRIS are affiliated with one of those 9 nationals, and IRIS is affiliated with CWS, Church World Service. The next acronym is SIV. You may have heard that a lot recently, especially since the crisis back in August of 2021 in Afghanistan. SIVs stands for Special Immigrant Visa, and that's a terminology that was used to apply to certain individuals from Afghanistan and Iraq who applied for and were granted this status based upon their involvement during the conflicts in those 2 countries, particularly as it related to assisting the United States government. And that SIV status also includes the participants' immediate family members. RNP stands for Reception and Placement. It is the refugee and SIV resettlement program with which IRIS operates within the funding that we get for direct aid and services within the first 90 days after a person arrives in the US. The APA stands for Afghan Placement and Assistance. This is a new program that developed after the current Afghan crisis. It parallels the RMP program in that we receive funds to assist those arrivals within the first 90 days. And it's the benefits that folks arrive in that program as compared to the SIV program are the same. So they are, welcome, and, the statuses may be different, but the programs that they are eligible for are the same. Finally, PCICM stands for Preferred Communities Intensive Case Management. And that's the program that funds my work at IRIS. It's a special grant for ORR eligible clients. And these are clients who have special mental health or other needs, a variety of circumstances that they have been facing, perhaps qualify them for the program, and they find themselves struggling to navigate different systems in the United States. And groups include young people who arrive without parents or permanent guardians, who have spent an unusually long time under refugee conditions, single parents, women at risk, elderly refugees, refugees experiencing social or psychological difficulties, including emotional trauma resulting from war, sexual or gender-based violence, survivors of torture, members of the LGBTQ+ community, refugees who are HIV positive, and other populations with physical disabilities or medical conditions. And for these individuals, the PC program affords them a fixed term to overcome the barriers that they are facing. The client works in our program anywhere from 6 months to a year. And we start out with a pre-assessment in which we ask 7 or 8 questions to a client who has been referred to our program in a very discussion-based format to determine whether they are eligible and whether they qualify, and also to give them a description of, if they enroll in our program, what that looks like. Because it is an individually based program, they have the ability to say that they don't want to be part of the program. However, the difference between the PC program and, say, RNP or post-RNP after the 90 days is the level of involvement that I, as the case manager, have with a client. I work closely with them during the 6 months to a year time period to develop a self-sufficiency plan. Start out describing what a goal is and what steps they can take in their lives to achieve that goal. Typical goals involve anything in the realm of basic needs to stressors in their life. Perhaps they have they are part of a large family and they are struggling to get work, or they're struggling even to leave the house, and there may be some unaddressed mental health issues, or it could be a combination of mental health and medical issues. Sometimes there are things that have been not talked about for a very long time, and people have been in survival mode because they have been on the move for so long, and then they arrive here and it takes them a while to understand that help is available and that there are supports available for them. So a lot of my work is building a relationship and guiding a person to not only trust me, but to trust that I can refer them to other folks who can help them. We talk a lot about counseling and what counseling means. And the work addresses our most vulnerable of our clients. And for that reason, it's unique. And so I thank you for the opportunity of describing it.
Thank you so much, Sharon. Also for clarifying all those acronyms which we hear about and we don't always know what they're talking about. I will invite the participants to put their questions in the chat box, but just to get the conversation started, I would like to ask, we know that mental health issues and including substance use is very sensitive, potentially stigmatizing topic. And I'm wondering if the panelists can share with us, how do you and how can all of us kind of make it a little bit more possible for them to talk about whether their own mental health issues or their children or their partner, etc. How do we help them be more comfortable bringing that up and not feel reluctant to do that? And also, if there are any examples of a conversation that was successful, but also a conversation that frankly didn't work out, I would really appreciate any insights you have. Maybe we can start with Dr. Annamalai.
Sure. So, what I find useful generally is to just sort of normalize it as much as possible. So when I speak to them, I might say something like, we see a lot of people in this clinic that have come through similar experiences like you, and we've heard very difficult circumstances. And I want to ask if you experience something like that, and then I might, be more specific. So I think making it seem like we ask, and which is true, we do, we ask everybody the same thing and we are not sort of singling them out. I think that's definitely helpful. And sometimes also the way I get to it is if I sense that they are reluctant to talk about anything related to mental health, I might start off with something like sleep. You know, that's a common one people are very fine with telling their doctors about. So I'll start with how are you sleeping and how are you doing, or like how are you feeling, you know, coming here and adjusting. I'll start with very general terms, then I might get to specific symptoms like sleep and pain. You know, we don't think of pain as a mental health symptoms, but often they do present with physical pain. So I'll start with that, and then I'll sort of get into like, what do you think, you know, why do you think you're not sleeping? And then sometimes I'll go into a little bit sort of education mode, and I'll say, you know, we see a lot of people who have sleep issues when they're struggling to adjust and when they're very stressed. And, you know, maybe it would be helpful to, you know, get some help for your sleep. I might not say help for your mental health issues or for your depression. And one thing is the depression that we very loosely use as a word in English is like very difficult to translate. The exact translation is not even there in many languages. So I tend not to use that word per se. I'll say something like, do you feel you're sad, or do you feel you're happy, or do you feel like you're kind of just, you know, in the middle, or something like that. I'll try to break it down. As for examples, I find that once people, so one more thing, so people who had enough distress that they've had to like see a counselor or a doctor in their own country, I feel are a little bit more amenable to hearing about it, because they've already had that recognition and awareness that there is a thing such as a mental health issue. So I think when I've approached it that way, I'm just trying to think of if there's any specific example. But when I say, you know, you can get, and I usually don't say like, can I put you in touch with a therapist or a mental health practitioner? I'll say something like, there are people here who can help you talk about your issues. And I know they can't solve your issues, but they can help you cope with it. And they can help you maybe deal with those issues and still do the things you need to do, like look for a job, etc. And when I put it that way, I mean, they're a little bit more amenable to it, depending on their level of distress. And some people will say, that's not what I want to focus on right now. And that's okay. You just kind of need to give them time. But on the other hand, sometimes it's just hard to get through, no matter what you say. And I've definitely had one person I remember from a while ago, he actually would not, I mean, he was coming in with sort of vague, multiple like physical symptoms. And I think there was a lot we could tell just sort of mentally, he just was not telling us. And even though like, I even try to frame it as like, I'm a medical doctor, you know, you don't have to think of this as a mental health visit, you know, you can just talk to me. Even the hint that there was something even remotely like in his mind, like wrong with his mental health was something he just couldn't tolerate. So, I mean, it doesn't work all the time, but I mean, sort of those are the tactics that I try.
Thank you so much. Ferishte, do you have any insights about how you support the refugees so that they're comfortable talking about some of their mental health issues?
Give me 1 second, please.
Sure. If you want, we can switch to Sharon and then come back to you. Sharon, would you mind?
Sure. I think a lot of the work is about dispelling myths, you know, and getting into conversations with people that counseling is not just for crazy people, or, you know, someone who's emotionally damaged or has something really wrong with them. As Dr. Annamalai said, normalizing it. And we haven't really touched on it a lot, but the last couple of years with COVID, things really had to shift. And where we weren't seeing people in person, there was more of a possibility, you know, for mental health issues to not be addressed. You know, we weren't knowing, say, that somebody wasn't leaving the house or wasn't eating or getting enough sleep, or even taking care of their children. You know, you could glimpse it a little when you'd hear about children that weren't showing up, say, for virtual school, you know, or, you know, moms who, you know, weren't socializing with other moms. I mean, recently I was working with a client who sustained a great loss in her family, and there was a lot of unaddressed grief going on, but she had other children that she was, really focused on. And we talked very briefly about counseling, and that, there were people that could talk to her besides myself, that even though I'm not a therapist in my work, but it is a therapeutic setting. And that's a distinction that people are not always aware of either. And, every once in a while I would bring it up, or I would hear that, she was, not going out, not doing things. And after several months, she contacted me and was suddenly interested in going to English class. And fortunately now our English classes at IRIS are in person. And it's part of a family literacy program where moms can come. It's for, at this point, it's for women. We don't have the space to have separate classes for men. And there's a daycare component. So moms with children under 3 can bring their children. And she had a child under 3. And I connected her with English class. And she's talked in English class about how she's feeling. Not ready yet to access any kind of sort of quote unquote mental health services, but just the socializing and the knowing that she's in class with other people who are also, striving to learn English. In my mind, we've taken a step in the right direction. So it's really seeing what people need and how we can get them there, no matter how small that progress may be.
Thank you. Thank you for that. Is Farishta back with us?
Yes, I'm here.
All right.
Yeah, regarding the question that you mentioned, as you all know, the crisis happening in Afghanistan recently, even we had the war for 40 years, but that was kind of really getting a new government or new facility, like the government that no one had a good experience with them before. And with this situation, it affects 100% to the people, Afghan family who are living here. At Eleanor's Light and myself personally work more closely with Afghan community here. And I see how that affects a regular life of a normal person who never had mental health before. But right now with this situation, they're all worried and under stress every day regarding their family members back home in Afghanistan. Even if the people who don't have, which is very most unlikely, many people, they have relatives back in Afghanistan, even if they don't have it, still seeing the news and, every day people being under different rules and regulations, it affects brains. That's a really big concern I had. With the research, and I mentioned it to you, we do with the Yale School of Public Health and the Gaylord Hospital. I wanted to mention and address this. When you're talking and doing the research or doing the work with them, talk about this and ask them how difficult is the life for them right now, how this make it harder for them, and how we can help them to make it better. We are trying to have some legal work, some advocacy work for the people who are on the list of evacuation, but are still in Afghanistan. They don't have way to get out of there. And they are working with the US government indirectly. That's why they are kind of delayed and cannot come to the US. Would be good to have some kind of support at that area to at least keep them to a safer country, if not the US, somewhere else, to not stay at these circumstances, or forcing the new government to give them, to let them what they want, but they're not pushing the families in Afghanistan. As you saw maybe recently, it's really heartbreaking when you see a woman stay in front of TV and say, I'm a human. My right is go to school and get education, and I don't have that right. Seeing this, a human cannot go to school, which is love, and I had same experience of, while in my life, wasn't allowed to go to school, and I understand her. now I'm not complaining about that part because it wasn't my country. But for her to being at your home country and not allowed to go to school because of the people who are controlling your life is heartbreaking. Right now, I believe for Afghan people, mental health is in the high standard, even in the country or outside of country, no matter where they are. They are right now in attack of many other issues, which is going to bring a lot of mental health, a lot of health illnesses in future because of this evacuation in August of 2021.
Thank you for that. There's definitely some research that shows that exposure to conflict can unfortunately bring some violence and abuse inside the home, whether it's interpersonal violence, family violence, child abuse. There is research showing that sometimes that exposure to conflict has negative impact within the household. Is this something any of you have encountered? And also, what are your thoughts about how this could be addressed? Maybe we can start with Dr. Annamalai.
Yeah. So somebody actually had asked a question about intimate partner violence, and I had responded a little bit. So, we definitely see that, and actually Farishta might have more because she sort of, interacts with the families on a different level. But what I find it very hard is just to determine when something is considered like appropriate within their culture and when something is not. And I've definitely had some people say like, oh, and often, I mean, not to group people into categories, but often like it's a woman who'll say, like, he was actually beating me until he came here, but he's not now because, he's kind of learned that that's not how we do things here. And I've definitely had people not understand me when I ask about like verbal abuse, and I find it hard to frame it. And I'm always looking for the right words to ask it. It's somewhat easier to ask about physical violence, but sexual violence and verbal is a little difficult because I think some of it is considered part and just parcel of what it means to be in a relationship and in a marriage. So I think those are the difficulties we face. And I think we may be missing a lot. I mean, we do try to screen for it routinely. And, we hope that we do with time and they get used to us that they will disclose, even if they're not disclosing in the beginning. But I'm sure we are probably missing a lot of the violence that happens simply because, they're not that willing to accept it. But again, Farishta might have more insights into this.
Thank you, Dr. Annamalai. Thank you, Dr. Annamalai. Yeah, as you said, there is one thing would be good to me to like everyone, or including myself, understand some of these mental issues in Afghanistan are not related to just a mental issue, it's just a culture. For example, hiding your feelings and you're keeping everything inside of your family member or something that it's a culture. It says if you want to have a safe home, then keep everything inside the home. Don't take it outside the home. Even if you have a verbal abuse, even if you have like beating or anything. Personally, I had one of the interpreters. She's working with us for several years, and I know her like on the street when we had I believe we had a clinic at that day for the COVID vaccine. I repeated several times the question. She said, I have kind of dizziness, I cannot hear you well. When I asked her why, she said, because this morning my husband beating me and my ear has pain, I cannot hear you well. This afternoon I will go to doctor. I told her, please mention that to the doctor. And I can mention it to doctor too. She just started giving me, please don't do that. I trust you, I told you. If my husband knows, the life gonna get even worse. And then after a while, as you said, Dr. Annamalai, when I follow up with her, she said it was just one time and nothing happened again. But I knew this happened again. But they cannot talk about it. This is a culture, the way we are thinking, we want to keep safe our family, especially the kids that are with us. If we say this in future, like many other organizations will come, and then we cannot keep the family, especially the children with us, based on culture and the way we know in the community, no matter who is far, the kids will stay with the father. This idea, this mentality, keep the woman, as a mom, I understand that it's really hard to get separate from your children. That's why they keep everything inside. Unfortunately, verbal abuse or things is never mentioned and never talk about it. Would be good to have orientation or something to inform the families about it.
Thank you. Sharon, do you have any thoughts to share about what's happening inside the homes? And
yeah,
what
kind
can
of
be
to
done?
add to what Farishta said, during the initial orientation when families arrive, we talk about all these, intimate partner violence. We talk about, not hitting your children, not hitting other people in the home. But that's at the very beginning when they are just flooded with all kinds of information. So as time goes on and, relationships build, you do hear about things. I actually just last week, I'm working with a teenage boy who has intellectual disability as well as some medical impairments. And so I'm working with his family to get him Social Security benefits, SSI benefits. And last week, his mom asked if I could meet her outside the home, in my car. So I picked her up, she got in the back seat. And, I have an interpreter on the phone because she doesn't speak enough English to really communicate well. And she, after knowing this woman for maybe 6 to 8 months, she started telling me that her husband is hitting her. They're talking about divorce and, there's 5 children in the home. And that it's a really difficult conversation to have, and the trust that someone has to tell you that when that's not, culturally, that's not something that you talk about. It's not something that people want to hear about. And to be, to have that level of trust, to know that I'm going to have to tell other people, that I'm going to have to get other people involved. We're going to have to, contact state authorities. It's huge, and it has to be handled with like the utmost sensitivity, and at the same time acknowledging how difficult it is for someone, and that safety is our number one priority for everyone. And also, not victimizing the perpetrator, because there are differences in where people are coming from all the time. So it's such a complicated issue, and fortunately we don't see it all that often, but at the same time, does that mean that it's just not talked about? So it is something that we have to be prepared for when it happens, and we are.
Thank you, Sharon. I'm looking at the agenda, and we are now going to transition to session 4, which is a discussion with all the speakers from earlier this morning and panelists now. And then we're going to open it up to questions and answers for all of them.
Great, thanks, Kaveh, and thank you to the presenters for the excellent discussion about working directly with newly arrived refugees and some of the challenges that are experienced. I'd like to just briefly invite the members, of the panel and all the speakers today to join us for this open panel. And I'd like to invite the audience members to prepare your questions and type them into the chat. We'll have about 20 minutes or so, I think, to talk about some of the learnings from today. But just in preparation for that, I want to thank all the speakers and just remind everyone all that we've learned today. We heard about the war on Ukraine and the crisis that is affecting patients there who are living with HIV and grappling with opiate use disorder and the challenges of redefining sustainability and vulnerability in that context and thinking about logistics. We heard some excellent presentations from our NIH representatives, Holly Campbell Rosen, talking about some definitions of what we mean by human health and mobility and some of the research programs that NIMH is funding. And from Blythe Beecroft about how Fogarty is taking an important stance in defining the research agenda and bringing to light humanitarian researchers around the world and helping them build a community and move forward as we can address some of the gaps that were identified. We then heard from Dr. Jeremy Kane and Dr. Kelly O'Loughlin, who talked about their work in low and middle income country settings, particularly in sub-Saharan Africa, looking at the integration between substance abuse, and mental health issues and HIV, and also community-based approaches to delivering antiretroviral therapy, linking people to care. Finally, in this last session, we've heard a little bit about the challenges that newly arrived immigrants, the role of stigma, the role of mental health, the role of intimate partner violence, and some strategies that these practitioners have used to address that. So with that, we'll now maybe open it up to the group. And I thought maybe one interesting way of talking about this is that we have had some presentations thinking about low and middle income countries. And I think often humanitarian crises, we think abroad and we less think about some of those situations we have in our home. But in the program that we're developing here at Yale, we do realize that there are all sorts of challenges. We've heard a little bit today about individuals crossing the southern border without documentation, some of the challenges they may experience, about natural disasters. We didn't talk so much today, but we can think about wildfires and hurricanes that have affected people living with HIV, created risk for people living without HIV in terms of exposure to HIV. And I just wonder, are there strategies that the group has seen where we might learn from some of the types of strategies that are working in low and middle income countries, sort of reverse innovation, if you will, and bring those back to the United States?
I always wondered if, and I would love to get the providers' input on this, but an intervention like I talked about with CIRA, which is, a lay provider delivered intervention. So up in Montepala, it's actually being delivered by refugees themselves. And we found in other contexts that, like in Lusaka, it was delivered by community-based healthcare workers, and it seems to be very effective. And I've always wondered, is that a model that could be used like in a place like the US, given that, we talk about a treatment gap in LMIC, but there's a treatment gap for mental health in the US also, right? I mean, right now, if you want to get an appointment with a counselor or like a mental health professional, it can take several months, right? I think. And so I know that there's kind of licensure issues potentially, but have you guys ever thought about, or do you think there would be a space alongside like professional services that people deliver for some sort of evidence-based but lay counselor delivered intervention here in the US? And I don't know if there's precedent for that or if that's been done, but it's something that we've sort of thought about a little bit over the years.
Yeah, Dr. Annamalai or Freshta or Sharon, do you all have experiences with using peers to kind of help address these issues?
Yeah, so I think Freshta and Sharon, you might have more to say on that, but I know that, well, for example, Yale New Haven Hospital actually has a program where, they give a little bit of training, and then you can actually then like turn around and you can be a provider, but I think that's limited to sort of community like health navigation. I mean, it's not like actual like behavioral counseling or treatment. But I mean, I absolutely think, we should. And I think for sure that is something, yes, we have a different kind of gap in the US, and we should be training other peers to do a lot of peer-based work. I think, and you mentioned that, I think, Jeremy, briefly, like, I think we often run into these issues of like licensure and credentialing. And I feel like there are so many more barriers here than in LMICs. And sometimes, we do that because, we want high quality output, and we want, to basically like, have a way of measuring what we do, and we want people to do the right kind of work. But often I feel like sometimes LMICs, in other countries can do much more than we can, simply because they don't have these barriers. Even completely certified, trained professionals who are just not working in the healthcare system we are working in, who may be working at the VA, like I can't have them come and just do work here. And then like talk about peers, who is many more layers. So anyway, I guess my bottom line is I think that's definitely something we should be building up. I just think there's a lot of barriers, but I think they're very workable barriers. And we should do more than, I think there's a lot of thing about peers doing community navigation, which is absolutely also needed, I think, but we should take that one level up.
So if I may, this is a topic that the Center for Global Mental Health at NIMH is very interested in. We call it reciprocal learning. There are other terms for it. We're collecting examples, and one that comes to mind is Dr. Vikram Patel has worked extensively in India and recently with other partners here in the state received a large grant to work in Texas and implement his technology that he used in India to train lay workers to deliver depression treatment. So they're testing out the ability to use lay people to deliver the depression treatment in Texas. And so it's the experiment that I think you're asking for.
I think another issue that comes up a bit, and we also discussed, I think, in planning for this symposium, is the voice of people who are displaced in this research agenda, which I think is also an issue of implementation of public health ethics. I wonder if any of the panelists could speak a little bit to your experiences in terms of figuring out what research questions populations are interested in, and how you might approach sort of co-creating or disseminating the results of research. Do you have any experiences doing that? And what might be some suggestions for those who are thinking of getting involved in this research area?
Yeah, let me talk a little bit about this area. During the several contact with different researchers working with us, and also seeing the Afghan families that we are working with, what I saw is more they'd like to have, if there is any research involved, there is a program next to it involved too. If there is a program at the end of the program, then there is a research that would be more interesting of the people. And then because they already went through that process, it would be easier for them to answer the question and tell you the experience. This is what I learned from it. The researchers are less scientific, it's more interesting for the human, like a normal average humans. Regarding the previous question, if I hope I get it right, you said it's hard to even making a payment and take several years. Yes, that's a big barrier and big issues. More important on that is when you even get the appointment and go for it, it's hard to find the right interpreter to help you, especially it's a big barrier for the refugees and immigrants who are, English is not their first languages. Because when they are at the setting, it's hard to find interpreter who translate the exact sentences as the provider mentioned it to their clients. One other thing would be here at I can say is also mainly the language barrier. The second area would be the cultural things. It's a different culture, two different people from different level of education going to mention one thing. There was another thing and I forgot immediately from my mind. When it's come back, I will let you know. Thank you.
Thank you so much, Farishta. Kelly, I think you had a comment.
Yeah, one example, it is tricky and it's something that I've tried to do as far as drawing on the wealth of information from the community, the desires of the community, and also stakeholders. And actually one tricky part is that sometimes the goals are different, of course, of each of those different parties. One thing that, first of all, I took a wonderful course from Maastricht University in Belgium called Intervention Mapping, and it's a week-long course. It was pretty cool to come together with people from all other countries, and they have a whole PhD in this discipline. So it's a quite intense model. But I did my best to implement this model in Nachavali refugee settlement over a workshop where I invited stakeholders and community members to come together. And basically the model is pretty intense, but you share background, share information, you come up with what model of health behavior theory you're trying to use to come up with the change. And then you work together to design the intervention and kind of iterate the process. So it's just one example of a way that I worked to try to do that in Nachavali. And then in terms of the dissemination, I'm always also looking for better ideas about how to do that. So I hope people can share. Of course, we publish. I definitely, every time I'm in country, host meetings at my research site to share information and to get input on next steps. And then I also do that kind of at the country level with organizations and stakeholders and at the Ministry of Health. But I think where we all need to do a better job is bringing it really right back to the refugee settlement or to the refugees. And part of the hard part is there's so many languages. I mean, my studies lately are in 9 languages, so it's quite tricky. And also, I never think to write that into the budget. So I'm getting better at it as I progress along my career and being more thoughtful about that. But that's something that I struggled with early on, was not kind of thinking ahead to that end part.
I think another interesting topic to talk a little bit about would be the role of government actors. We talked a lot about academic research. We've talked a lot about community-based organizations and NGOs. But I think many of the crises that we're thinking about, involve government and may involve difficult political and/or economic issues. And I just wonder if any of the presenters could maybe share some examples of how they have tried to navigate that. What sorts of partnerships have helped them in their various settings to to work with government to address some of these issues, and what are some of the challenges of working with individuals that may be coming from quite a different background in terms of their perspective, sometimes outside health.
I can speak to this a little bit because I had the privilege of working directly with the sections of the Ukrainian government in the past. And the challenges are ample, and some of them are resource constraint based. Some of them are personnel based. Resource constraints means a lot of the programs requires costs and requires direct funding, and some of the fundings are not available. Or there might not be enough understanding in the political circles regarding the priorities and the importance of some of the programs, especially if the maintenance of such programs have long-term effects. There's also a general, I think, in the context of what we saw in Ukraine was a problem that some of the policies that were formulated were not always driven by evidence-based thinking, and this data was not often used to implement and formulate policies. So a lot of the challenges as both advisors, we often have to take advocacy role and start from ground zero in terms of defining the problems and setting the targets such that the policymakers would be willing to take actions and use the power willingly.
Has anybody been able to, I know many people in the audience will be interested in obtaining funding for their work, either to provide care and services to people that are affected or to advance the research agenda. And, we heard about some of the nice opportunities that exist at NIMH and in other parts of NIH, but are there other government agencies within the US government or NGOs that you'd like the audience to sort of know about that could be helpful for getting started in this area?
I would recommend Grand Challenges Canada as a source to look at. Yeah, it's the one that comes to mind.
And I would add, I just see someone put this in the chat, but R2HC, I think is, as far as we know, the only game in town in terms of funding specifically focused on humanitarian crises and humanitarian health at large.
Yeah, I was going to say that too, Blythe. It's what's great about that. There are many great things about them, but they fund research in humanitarian contexts, which is somewhat of a rarity. I think a lot of people are interested in funding programs, very understandably, in those types of settings, but it's really important that obviously we're doing rigorous research there as well. And R2HC, I think, is probably the preeminent organization that actually is interested in doing that.
Yeah, thanks for those suggestions. So we have a couple more minutes, and then we're gonna at the end just sort of wrap up and share some of the future opportunities that we want to support. But before we do so, I'd just like to invite any of the panelists or any of the audience. Is there anything else that we should be thinking about that we didn't have a chance to talk about today, whether that's in terms of the research agenda or you know, the individuals that are affected? If there's anything that anybody wants to bring up at this point, be wonderful to have your perspective.
Hello, my name is Shimimana Valentine, a refugee from Burundi, working with Washington University. I'm the one of beneficiaries who benefited from Dr. Kerry research, the same as my fellow community. We are really thankful for the work done by Dr. Kerry, and we really request for more, so that our community can benefit. We still need more to do about our people in the community who are suffering from HIV. We have done a lot. We have done HIV testing, we're into care, and we still do more, because our people who are on arts, they are facing a lot. They are facing a lot in their viral load and suppressed, because some of them, they are lacking what to eat. Others, they are just there because they don't have psychosocial counseling, because most of people here, they need more intervention, and they are lacking a lot of nutritional support when they are taking their drugs. Thank you so much.
Thank you so much, Valentine. And I see that Valentine's been working as a research assistant with Kelly O'Loughlin in their work in Nachavali refugee settlement in Uganda that many of us heard about at the beginning of the session. And it's wonderful to hear your voice talking about the issues that we really all need to be thinking about and addressing. Also, maybe invite Josiane Mumukunde to unmute herself and ask a question.
Hi, everyone. Thank you so much for this talk, Arendera. My name is Josiane. I'm a former refugee from Rwanda. I'm resettled in Connecticut, actually, also. And I'm an incoming student at the Yale School of Public Health. So I'm interested to know, because we talked about substance abuse and mental health. I'm wondering if there is also any research that's been done regarding, because a lot of time I feel like people with disability are left behind. And I'm wondering if like disabilities in terms of forced migration, and if you are also in some of the interventions you mentioned or some of the programs you are running, where does people with disabilities in terms of forced migration or who are in humanitarian crisis, where do they fall in? What kind are you including them in your research or in your programs? Thank you.
Thanks. I don't know, Jeremy or Kelly, would you guys want to talk about that? Or Alexei?
I don't have it's a great question, and congratulations on starting the program at Yale. It's really awesome. We never would exclude anybody from being in one of our studies for having a disability. It has never been a focus necessarily of our own research, people with mental health plus other disabilities, but it certainly is important. And I think should be a priority for future research in this area for sure, but it hasn't necessarily been a focus of ours.
Similar with my work, although I think the more that HIV care is differentiated, then the more accessible it becomes to many people.
Great. Well, I just want to thank everybody for participating today. It's been enormously insightful and learning and inspiring actually to hear all the work that you all are doing. So thank you for taking your time to share with us. We hope that this won't be that this will be the beginning of many more occasions where this community gets together and helps to try to address the issues that you all have highlighted and advance the successes and the frameworks that you've shown us today to think about really integrating care. I think that's the big message that's come out today, is not to work in silos, but apply our research methods, our clinical and public health strategies to carry out ethical, engaged, and highly impactful research and care. So I'll turn the microphone over to Denis Harsuno, who's going to tell you a little bit more about some of these plans. And thanks again.
Thank you, Luke, and thank you for all the panelists. We would like to continue this conversation, and we actually have 2 more events coming up. One on April 18th is a virtual panel looking into the ethics of HIV/AIDS research and practice among vulnerable populations impacted by humanitarian crisis. And we will also have a CIRA at Yale workshop. This is intended for early career researchers who are interested in conducting research in this area. And it will be a 3-hour workshop on May 19th. And I believe that the links to register to these events are available on the chat. So please feel free to share with your colleagues or register yourself to attend if this is of interest. And one last thing is, just again, thank you very much for our speakers, panelists, and moderators, and also to our research team, support team. And because we are interested in convening additional events or programs related to humanitarian crisis, we would love to hear from you. We will send a link, the very brief evaluation survey. We would love to hear from you about what you think is you appreciated from this session, from today's session, what is missing, what are the topics that you would love to hear that we could organize in our future events. And again, as a reminder, all the resources, recording, and the slides will be available. We will send it by email and also at the CIRA website in the coming 1 or 2 weeks. Thank you again. Thank you, everyone. And I know that it's nighttime for some people in Asia. Thank you so much for attending, and everyone else in the US and abroad. This is a very important topic, and we really appreciate your participation and support of this conversation and discussion. Thank you.
Thank you all.